I feel like live from New Hanover Regional Medical Center. Did you hear the announcement overhead? So we just went live with all of our Zoomers and virtual reality. So let's go ahead and get started. Good afternoon, everyone. My name is David Glendenning. As you can see on the slide there, I work with the fine folks that work with the transportation division of this hospital, ETS, and specifically the Emergency Medical Services Division. We have lots of people in the virtual world, ranging from fellow brother sister hospitals out there, as well as EMS agencies. So I want to thank Casey and Deb for allowing us to open this up to Zoom. Usually I do these courses for Cape Fear Heart and for newer and academy type nursing folks. And they said this year, hey, since we've got this ability, why don't we open it up to many more people? So hopefully this works out well. I can promise you, working a live audience in front of me and a virtual audience is going to be a new experience for me. Usually when you do a Zoom, you're sitting at your desk, you got your feet up, you can't see it, right? You just see the presenter's head. You have no idea what they're doing, but they're working through slides, all that stuff. Yeah, so we have two different things that we have to do here today. So bear with me as I'm moving through the slides. I'm gonna have to pause and make sure I light things up so everybody in virtual world can see it. Virtual world, thanks for logging in. You have all been controlled as far as being able to speak. And that's only because we need to keep some kind of order throughout this, because you're not in front and I can't see if you're raising your hands right now. So you are surely welcome to participate. If you know how to work Zoom, that's good, then you'll know how to put in questions. And my fantastic assistant in the AV department will be your questions, but we won't have them immediately. We'll try to answer them as soon as he feels it's appropriate to break with me and ask me to relay the answer to the question. Okay, everybody ready? Everybody knows the rules. Make sure you're socially distancing. I see a lot of mask wearing, a lot of not mask wearing at the appropriate times. That's good because you're eating. Anybody eating anything good? I haven't eaten lunch yet. No? If I start slumping over, you're gonna bring me something? A little snack? All right, perfect, perfect. I do have some coffee, so that should help get us through this. But yeah. All right, so let's get moving on. We're gonna have some breaks. Those of you at home, you'll be able to get up and run and do some stuff here about, I do not lecture straight through. I give 50 minutes and then a break, usually right around an hour, because your brain is gonna disconnect me from 50 minutes. That's just the way education goes. And I'm hoping you retain 20% of this stuff here today that we're gonna be talking about. So I can't see this at home, but show of hands in the audience. Everybody here thinks they're an expert at 12 leads, right? Okay, good. No show of hands. That's why we're here together, right? And it's going to be a long, long, long time. Maybe you'll never become an expert at 12 leads. I'm here to teach you the base stuff to keep you out of trouble and to maybe pick up on some good things that are a little bit more advanced. So if anybody's thinking you're going to learn all about access deviation here today, forget about it. Anybody here from New York? Forget about it? Know what that reference is? Yeah? Okay, a couple of you. All right, yeah, we're not going to get that advanced because I don't teach our medics that. And I don't teach brand new medic students that, and I would definitely never teach critical care nursing that as well. Because when you start getting too far into it, if you're not good at your base, guess what happens? You start making the wrong calls, right? The wrong calls. And when it comes to 12 leads and STEMI recognition, which is one of the biggest things we utilize 12 leads for, that's the name of the game, right? Getting that call correctly. Because I hear it costs some money to activate a cath lab. Is that true? A lot of money? Yes, yes, it does. And it's part of our responsibility to make the right call rather than just defaulting to, well, the patient, I'm just doing it for the patient to the tune of a $20,000 activation fee, right? It's, we have to be a little bit more smarter with our healthcare dollars, and that means better education on 12 leads, so we make the right call. Here's the objectives I gotta show you, right? The end, we're gonna do a lot of practice cases. Inside audience, you're gonna get clickers issued to them, or we're basically gonna say whether you think it's a STEMI, or it isn't a STEMI. The audience at home, you'll be able to see how they feedback, and then of course you will secretly be able to keep it to yourself that you got any wrong. But in the room here, we'll see how the room's breaking up. That'll be pretty much the second half. All right, so what is the point of being advanced, or at least having a solid base? Is it to win these awards? We get these awards consistently in the region, right? All 7 counties feed into this cardiac tertiary center, and we do a hell of a damn good job, don't we? I'm sorry, not supposed to swear. Heck of a darn good job. We do. We get these awards consistently. The partnership that we have with EMS agencies and our critical care division to bring these outside patients in directly to our cath lab, and the fantastic teamwork that we have here, we do a good job. But ultimately, it comes down to this. We have better patient outcomes. So that's why we do a good job, and that's why we get these awards. And it does start with early recognition of signs and symptoms in the public. And then the second thing usually is you and your education. So I like to show this slide. This is, you see, it was a few years back. We have, we don't activate based off transmission in this area, and we're proud of that. And sometimes the interventionist and the cath lab team has to pay the price when we start to slide a little bit behind on education, right? Maybe we haven't seen a 12 lead in a couple of months. Believe it or not, in EMS, we don't run a 12 lead on every single patient. I'm assuming in the hospital or in cardiac rehab or wherever you're at, you don't run 12 leads on every single patient. Is this true? Yes, yes, absolutely. We usually do it when they start having signs and symptoms, or maybe it's ordered by a physician. So sometimes we start to forget things. So if we don't stay on top of our game, this is the kind of stuff that starts to happen. And you see those big launches there in false activation, 40, 45%, almost 50% false activation rates for months. You can imagine how the cath lab team was losing their mind. So we took a huge education initiative within our own EMS agency, made station books with EKGs. We ran continuous classes, beefed up the amount of 12 lead education we had in our initial courses. And as you can see, it worked. The second half, we were down 0, 0, 0, 0. And then you have a little bump up from time to time. But the same thing is going to happen in any kind of allied health position if you're not seeing it. So we are able to get to a 10% false activation rate by sharing the knowledge. So if you guys ever have a suspect 12 lead on a patient, make sure you do follow-up and see what the outcome was with that patient. See the continuous 12 leads that are based off this secondary stuff after your primary 12 lead. I tell all of our field providers, you have an old EKG on you at all times, and they just look at me and say, I can't access Epic. And I say, you sure do. It's the first one. If you see changes in the fourth one from the first one, is that reason to be concerned? Absolutely, absolutely. So always give yourself continuous feedback, right? Do follow up on the patient and see how the EKGs are after the fact and see if you were right, or maybe you were just off a little bit. Because really at the end of the day, it's not just A&P. It's about really understanding shapes and memorizing what something is supposed to look like and recognizing when it doesn't look like it's supposed to, right? The name of the game with 12 leads is realizing that's not normal, right? That's half the battle right there. So I'm not going to beat on your heads too much with some A&P, but we do have to talk about these important things here: sodium, potassium, and calcium. Anybody in the room want to throw out why I would have this slide on here? What's so important about these elements right here? Action potential, yeah. Absolutely. The heart can't operate without action potential going, right? Can your body operate without action potential going? Heck no. I'm speaking and grabbing my ideas out of my head right now via action potential that's taking place in my brain. If I go to move my arm up like that, action potential has taken place. Sodium, potassium, and calcium are so important, and so is chloride. And understanding that these are constantly going in and out at certain rates to get things to happen at certain rates is simple, right? It's very simple. Now, when you think of the heart, I don't want you to just think of this big structure, right? You got the two atria, you got two, well, down on the cellular level and past it, in the banding area here, this is what your heart is really made up of right here. It's muscle banding, like barrels, hinging together, right? All the way down to the smallest level is basically your hands interlocking, right? And without calcium to come in and activate that troponin you see in the middle there, you're really gonna have a hard time doing any contraction or any relaxation. Now, we all know what cardiac enzymes are, right? They get ordered when somebody's having chest pain or something similar to rule out a cardiac event. We know they are not absolute, but they are pretty reliable, sometimes more reliable than an EKG itself. You can absolutely have positive enzymes and a negative EKG right now, or an unremarkable EKG as I like to call them. So what common thing is elevated when somebody is having an MI and these bands start collapsing because they're dying, right? And this starts spilling into the bloodstream. Troponin, all right, yeah, that's an easy one. I like this slide because we always know hey, elevated troponin is bad. Almost always good indicator that they were having an MI. Not always, but when you look at that piece right there and think it dies and it falls apart and that troponin spills into the bloodstream, that's exactly what happens. And that's why, and then you lose the ability to contract and relax. Make sense? That's why you have such a bad day. Now, everybody here has a pacemaker settings in the brain, right? We know that the heart has this amazing ability to catch up, right? If the AV node detects that the pulse rate has dropped down below what do we got on here, 40 to 50? It's going to start firing, right? Less than 60, is that true? Yes or no? I see some yeses, I see some pauses. They're like, okay, Dave, I don't know which way you're going with this. Well, so a lot of us have been taught that, right? And that's absolutely incorrect. This is what I want you to take from this moving forward, because it helps you understand heart rates and why things can be elevated sometimes. You don't need to cardiovert them, right? It might be something to do with those elements going into that cup, lack of, or too fast or too slow. These pacemaker sites are all programmed to have potassium, sodium, calcium, chloride as its base go in and out in a timed sequence. You with me? The top of the heart, or the SA node, goes fastest. The AV node goes a little bit slower. The ventricles, the Purkinje fibers, all the rest of that stuff that you see on there goes a little bit slower. But guess what? No matter what, it's firing. So if the SA node doesn't fire, regardless, the AV node is going to fire. Does that make sense? So if you're in VTAC, right? VTAC, which is what? What's ventricular tachycardia? Which group of pacer cells here have completely taken over? What area of the heart? The ventricles, right? Guess what's still firing no matter what? The SA node, the AV node. Unless there's a reason for them to be out, doesn't matter. They're still on their timers. Does that make sense? The ventricles have decided to start firing in an upward moment greater than a rate of 100, most likely, and it's now overriding. But the SA node and the AV node is still firing. They're on timers. And too much or too little of those elements going in and out of that cup can affect those timers. Capiche? All right, good. All right, so vectors. Like I said in the beginning, the good news is we're not gonna jump up and down about figuring out axis deviation. It is important, but we're not gonna do that here today. But in order to really wrap our minds around how these EKG machines gather energy, you gotta understand there's a lot of energy coming off of the heart. True statement? Yes, absolutely. So every single one of those cells that's firing, right? Which troponin's getting locked in, every transmission's going good. We've got a mechanical reaction to an electrical reaction. They're throwing off energy. And like I said before, certain areas of the heart are on timers with those pacemakers. Some have a little less energy, some have a little more energy, okay? So when you're looking at the heart via 12 different views, those 12 different views, or those 12 cameras, are trying to pick up the energy that is coming out of the certain area of the heart that you're looking at. Capiche? All right, I don't see enough. Come on, I need some nods. All right, yes, yes, yes. I know it's after lunch. I know it's after lunch. At home, you better be nodding. All right, so you've got millions of these energies going off in different directions. At home, I'm waving my hands all over the place. You can't see it. They're going this way, they're going that way, because they fire and they basically explode out, okay? The cameras, their job is to figure out certain area, is that energy going in the direction that it's supposed to be, considering the view of that camera, all right? And this will make more sense in a couple more slides. So I know I wasn't going to talk about axis of the heart, but I am going to talk about it just a little bit. Normally, this is how the heart sits, and our main firing lead to, when we do continuous telemetry on our patients, this is the view that we're seeing, right? Top part of the heart is a negative, bottom part of the heart is a positive, the way that transactions across the heart, from the SA node to the AV node to everything else that fires after these pacemakers fire, okay? This would be your normal view. Now, if I was to take that arrow and flip it around to where the energy is going up towards the top part of the heart, there is actually a view in your 12 leads that shouldn't be able to see that energy coming directly at it. That's helpful in figuring out whether or not your patient's in VTach. Make sense? All right, you're gonna have a little more evidence of that later, but I think that it's easy to, it's supposed to be going down, all of a sudden it flips up. This camera that's way out here, looking at the whole top of the heart, right? A lot of us were told this view doesn't matter, so don't worry about it. It actually does matter because normally that energy is supposed to be going away, which would give you a negative complex. So it should be normally looking like A. So when a camera or any of your leads that are placed on the heart, when they're looking and they see energy actually traveling away, meaning the vectors were less full of energy when the view started, more energy as it's traveling away, you should have a negative complex, right? If that camera is directly on top and picking up the most energy coming out of these vectors, you're gonna have what's called a biphasic wave, or B. And then last, you've got that positive right there. That camera has a vector full of energy coming directly at it, and it's getting stronger and stronger until it dissipates. Hence the positive wave. Capiche? All right. See, this is easy. All right, so I have to talk to you about lead placement just for a second because I wouldn't be doing my due diligence because I have a, those of you who know me know that I kind of broke off for a few years from New Hanover, remained part-time, helping in the education department, but I got to do a lot of cardiac monitor training out in the field, and I learned a lot about how we blame machines more than we really should, right? It's easier in EMS to blame machines because what are our machines doing most of the time? Bebopping down the road, right? Bouncing. So we can immediately default to that, and that's true. None of these machines are really built for that. Imagine with a roll-in 12-lead machine, if you were shaking it the entire time, how good would your 12 leads be? Not so good. Well, none of these machines are really designed to give you a great 12 lead. So the first is you, the machine, and the patient need to not be moving, right? Need to not be moving. And you gotta have your leads placed correctly. So I'm gonna step off the podium, virtual audience, for a second, but you'll be able to hear me. All right, so how many of you were shown you need to put your wires down here, out here, way out on the end of your legs, and then out here for your extremities? Anybody? Couple. All right, so we're getting away from this, right? We're getting away from this. That is not where you need to put those leads. You can, right? You can augment all your leads that far out, but it's very difficult to get around your patient then. So why wouldn't you just do the minimum, which is as long as these leads are at least 10 centimeters away from the heart, which would be here and here, here and here, you're good to go. Anything just above the hips, as long as it's not on bone. Avoid bone. Always go for a little meat, muscle, or pandemic, you know what, right? Muscle, and try and go in the identical places on your extremities. So if you're gonna put it here in your bicep, it should be relatively even over here on this bicep. Make sense? Okay, now your precordial leads, right? Whether you're doing a right side view, left side view, appropriate view, they all kind of have to go in a certain order, right? But we know what those are. Now, it should look something like this. I got a little mouse to make it so at home can see. So we can see right here, these are relatively even here and here. And we do have these leg leads down. They're underneath him. You really can't see them too well. But you can see here V1, V2, V3, V4, V5, V6, right? These look to be nicely aligned. I can't tell you how many times I've seen EKG techs take those stickers and slap stickers up here and up here. You guys ever seen that? Some of you are EKG techs, and if you were shown that that's okay, that is incorrect. Those stickers need to come down into this area right here. The same thing with stickers out here. If you're not matching them up on the biceps in an even area here, then you're gonna potentially decrease the value of that 12 lead, okay? So make sure you kind of put them in the right spot. The other thing is skin. Skin is huge. Now, most of the folks in the hospital don't have to worry about dealing with the stickers except when we're gathering a 12 lead. But when you're continuously monitoring or you put a Holter monitor on somebody, you deal with these kind of leads, correct? Yes? No? Help me out. Yes? Yes, yes? Okay. Did you know that there are different kind of electrodes out there? All right, and the big difference between this one right here and this one right here is the connection. Can anybody tell me what the difference is between these grayer, almost black connections are versus this one right here? Okay, so one's actually, so this is more of a, this is true metal right here, which is the best connection point for a lead. The best, right? There's no manufacturer out there really that's geared up for these, right? So sometimes these are definitely not plastic. They still have to be a metal, but does anybody know what kind of metal? It's the kind that doesn't show up on x-rays. Yes, translucent. This is translucent metal, which means it doesn't show up on x-rays, which means your EKG quality is gonna be a little bit less optimal. But who wins in this war? Radiology. Radiology, right? Our pads too, the defib pads, we switched over to them in EMS. Translucent ones are the yellow ones that you see. And this is specifically so that radiology doesn't have to keep ripping this stuff on and off. So remember what you're dealing with there, because what happens is the lead connectors on the translucent connectors, they don't fit real well. And if you don't believe me, when you go back to your units or when you're on your EMS units, pop them out and put them on there, put one on, stick it on your hand and wiggle that. Wiggle the wire. It is so loose, you can feel it. So your patients absolutely have to relax their shoulders down. Make sure you tell them this, nice, slow, easy breaths, and tell them to not move, breathe still. Of course, you see some of them stop breathing. You're like, no, 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 keep breathing a little bit. And wait until you're completely done. Because even inspiration, expiration, holding the shoulders up will cause the wires to actually shake on the connection of that translucent connection. Metal ones, you don't have to worry about it so much. Skin. Every single one of you took a shower today. True statement. I hope. All right. Yeah. Okay. Well, I did. True statement. And I can promise you, if we were to put electrodes on the surface of our skin right now and rip it off as fast as possible, we'd be able to see some interesting things, right? That picture right there shows you how much dead skin just sits on top. I mean, we go through this shedding process every single second of our lives, right? This is how our skin works. And if you don't take at least a second to take a towel and briskly rub, I'm not saying turn it so red where your patient is about ready to punch you in the head, right? Briskly rub real quick, you are cutting down the chances of you having to do multiple 12 leads, first of all, but a really, really good 12 leads you can make an interpretation from. So do your skin prep. You don't have to wash them with soap and water. You don't have to get crazy with razors, but sometimes you do, right? Clippers, hopefully. But at the minimum, please, please take a towel and rub the surface, all the surfaces briskly where you're going to put those leads. You're going to be a lot happier in the end, trust me. And the last, is there a difference between gel and saline? One sticks better than the other, right? Okay, that's what most people think. Oh, they must have gel just because it sticks better than the other. Well, there is some truth for it to that statement. Well, let me clear something up right now. Do we defibrillate through electrodes? The answer is no, right? We absolutely do not. Why do you put electrodes on like you're getting ready to defibrillate then? Why would you mash them down, especially after we just talked about the quick skin prep, making sure you respect the connection that you have. The last thing you want to do is jam these things down onto your patient too, especially going through the center. They're made in the shape of a circle and a square for a reason. Anybody know what that reason is? So you can drive a race car after you put them on, meaning your finger should go around that electrode on the outside right here. Right? Not underneath it, obviously, but you will make a circular motion when you put it on. You practice this and you get in the habit of this. Trust me, it's real easy to do. You don't want to push on the saline or the gel because what does that do? It moves it around instead of just making a nice, clean contact on the skin surface. It moves it around and you literally create dry spots. You literally create dry spots because you've displaced the saline or the gel in an inappropriate way. The other thing is saline heats up quicker. Believe it or not, energy is measured better when it is not cold, okay? So in the wintertime, or if your patients are freezing, if your patients go to jump off the stretcher, out of the living room chair, or off the hospital bed, that should tell you it's cold, right? Give it about 40 seconds to warm up. Their body heat has to warm up that contact point. Does that make sense? Saline, it's usually instantaneous. Gel surfaces, meaning stickers or gel-placed electrodes, you absolutely have to give it a few seconds. Let it kind of warm up because the body surface will warm that gel. Capiche? How many people knew that? Not too many, huh? All right. See, it was worth it right here. You can go home now. All right, so we're going to talk about ST segment elevation primarily with 12 leads, and we're going to talk about some interesting cases, right, off the beaten path of STEMI recognition, because especially up on the units or in the homes of real interesting calls, especially patients that have been laying on the floor for hours, you can pick up some interesting things in 12 leads. So when it comes down to ST segment elevation, though, I want you to break it down like this. I want you to say, okay, I see this ST segment elevation, and now I got to figure out what bucket it's coming from. One of these three big buckets that Dave was talking about that fateful afternoon on a Wednesday somewhere in the distance. And it's, is it a cup issue, meaning sodium, potassium, calcium, right? One of the big three, or other things that could be awry, meaning metabolism. Is that the source of the ST segment elevation? Or is it a voltage issue? Is it a voltage issue, meaning do they have an enlarged left ventricle where we would have more energy and more vectors traveling across because there's more surface that energy has to go through that would be indicated on our EKG? That could be displaying normal ST segment elevation for that left ventricular hypertrophy, or LVH, right? Or is it just a good old-fashioned MI, right? Is it an occlusion? So is it from metabolism? Is it from voltage? Or is it from an occlusion? All right, so you understand these views, right? Safe to say, everybody here, before you hit the floors or you're about to hit the floors, I know that you've had some fantastic basic EKG education. Show of hands. Everybody here feel confident that they know what normal sinus rhythm looks like. Yes, 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 yes. Okay, all right, good, most of you. At home, I hope you're all raising your hands and your husbands or wives or children are looking at you funny right now. All right, so by way of review, each thing on that complex means something, right? And if you forgot, here's a picture of it. So your P wave indicates the SA node is firing right up here. And then we've got the P to R interval, which tells us, hey, AV node's starting to get involved. And we got the old R wave, which says, hey, firing is now running straight down the left and the right what? Yes, bundle branches, right? Now we've got ventricular repolarization or polarization. Polarization, right? And you know, it's gonna relax, start getting ready to do it again. And this is where we start getting into the ST segment right here. So your S and then your T, that portion right there, and then your T wave specifically. And then you see it's starting to turn red. It's red here and red here. What does that mean? Well, it's getting ready to do it all over again. There's a fancy way to say that, right? But it's the heart is getting ready to do all over again what it just did electrically, and then hopefully mechanically comes with it, right? That requires energy to get ready to do it all over again, right? Starting to feed up. The cup's got all those elements coming in a little bit faster, a little bit slower, okay? So even though you've just seen a QRS complex go by, guess what? There's energy going back the other way. But it's not like when the ventricles are firing out of control. This is the normal repolarization process. And this is why, if you choose to cardiovert somebody right here at this point, pretty much right in the middle range, beginning to the middle, guess what's going to happen to this wonderful electrical system? You're going to mess it up, potentially, right? That is when the heart is most vulnerable from outside energy, screwing it up. And this is why you select what on a monitor before you cardiovert? Sync, absolutely. So it fires only here, right? Only here on the R wave during this phase of the heart. This phase of the heart, all right? But yeah, there's energy going backwards too as it's repolarizing. Everybody here ever heard of a thing called benign early repolarization? And sometimes how that shows up in an EKG, and sometimes people can think, hey, they're having a heart attack. No, the energy going backwards is just a little bit stronger than it's supposed to be. And we need to figure out why. And 99% of the time, it's going to be because of the cup. It's going to be because of metabolism. Something is off. The repolarization process shouldn't be faster than depolarization. Agreed? I see some minds exploding. Anybody here that knows about BER, you now have a whole new understanding of it, because it's usually a dehydrated person. Extremely dehydrated. Younger, right? Younger. All right, remember what I said about memorizing shapes? It's all about what's normal. I'm telling you to program your minds right now to say the shape on the left is normal for the lead you expect it to be normal in. Lead 2, we'll call it, right? You got a normal, healthy heart. Lead 2, that's looking at just the surface front of the heart, picking up that negative down to positive, that one firing going all the way down to the left there. That's normal. Those measurements are normal. Now I tell your brain, the one on the right is not normal for that lead. Is it easy enough? Yeah. Well, so what actually can you see there? If you're like, hey, why do I have that little rocking chair bend in that R wave right there, also known as a delta wave? And what if my heart rate was about 140 times a minute? Guess what? It's going to be harder to see that delta wave because there's a lot of lines going across the screen. You're definitely not going to see it if you don't print out a strip. We're going to talk about that in the next slide a little bit more, the value of printing out 6-second strips. What condition is notoriously known with the delta wave? WPW, Wolff-Parkinson's-White syndrome. So not only by memorizing what's supposed to be normal and not normal, bam, your eyes are attracted to that, and then learning what WPW looks like, or the rocking chair, the leaning into that R wave. If you ever see this again, and you got a patient that's going 140, 150 times a minute, and you see that delta wave, you're going to be the genius in the room, right? Or you just ask the patient, hey, you got a history of WPW? And they say yes. You go, all right, confirmed it. And every once in a while, they don't know it. They don't know it. All right, who here has heard of this thing called contiguous views in a 12 lead? Contiguous views. All right, lots of hands going up. Take a sip of my coffee. All right, contiguous means anatomically close to each other, correct? We all agree on that? All right, so the rule of thumb is I don't have a heart attack or an MI unless I've got ST segment of how big? How big is my elevation supposed to be, guys and gals? How many millimeters? At least 1, right? 2 in certain leads, and we'll talk about that a little bit later. At least 1 millimeter, and it should be 2 or more contiguous leads. So those of you who are not familiar with this, here's the picture, right? Here's the picture. Anatomically, 1 and AVL together are tied together, right? Those would be called the high laterals. And then you've got your inferior portion, which is through the center almost, has a hard time picking up most of the posterior portion, but at least almost all the way into where the AV node is responsible for firing. The bottom half of the heart. So it picks up most of the right and the left ventricle all the way through the tissue. Inferior, lead 2, lead 3, and AVF for inferior. And then when we go over to septal, this gets a little more interesting. Numerically, it's got to be numerically in order, meaning V1 is contiguous to V2, or the septal views, right? V3 and 4 are contiguous to each other, or the anterior views. And then 5 and 6, now, these are considered the low laterals. Doesn't say low on there. Those of you who have your little packets and at home, make a mental note. Make them the low laterals. You need to learn that there's 2 different lateral areas in the EKG because that helps. A lot of times we'll forget that 1 and AVL are contiguous to each other. And you fly right through the EKG and you miss that there's 2 millimeters and sitting in both these, right? High lateral, way up high. Now I'm thinking potentially a left main, right? An occlusion, if that's where it's coming from out of my 3 buckets, way high on that patient if I just got action up there in the high portion. So to make it a little bit simpler, I've used this slide in all my basic EKG classes. And those of you who have printed it at home, if you want the slides, Casey, the same way that you registered, or just email me. You'll have my email address at the end. Or those of you who have Casey's email already, you can get the slides so they have all these pictures. So basically, in a nutshell, I know yellow here is, where's my mouse? There we are. All right, so here's your inferior leads, right? You can see, follow my mouse into here. Right, basically they look at, I'm going to cut it in half with this plane, that entire portion all the way down. That's the camera views for 3, AVF, and 2. And then AVR, this is that one that sits way out here and looks down and looks at the whole heart. Doesn't really see much most of the time, but when we start seeing things, global issues like ventricular tachycardia, which is nearly half of the heart firing back the wrong direction, pericarditis, an entire left main, a saddle embolus, which is the worst possible PE you probably could have. We're talking blood flow cutting off on the top of the heart. Then AVR can actually help us with some of this stuff. AVL and 1, high laterals. So they're looking at the high lateral portion of the heart. And then 3 and 4 and 2 and 1. So we got septal wall right here. It pretty much can pick up this whole thing from the middle down. And then we've got the anterior portion, which is a large portion of the front of the left ventricle here. And then 5 and 6 come in, they catch this low lateral portion down here. Okay, low lateral portion. So 12 cameras looking at kind of 12 different areas. What part of the heart really can't we see? The back, right? The posterior. It's really hard to see the posterior portion. Heart kind of has a little tilt to it, sits away from the back. That energy is not strong enough for electrodes to be able to pick up well on the posterior portion. Those of you who are saying right now, well, Dave, I'll just take 4, 5, and 6 and move it to the back and create a posterior view. My response to you is that you only pick up about 25% of the MIs out there that way. So don't rely 100% on posterior views. All right, so this is normal. This is normal, my baby. There it is. This is normal. When you start to look at these EKGs, start with your high laterals, and you're looking for a P, a Q, an R, and an S, and a T, right? Depending upon where that camera is looking, remember, primarily the energy is starting up in this top corner and working its way straight down. So if you got a camera that's down here looking at it, coming at it, it should be positive or negative. It's coming at it rather than going away. Positive, right? So you got to memorize that. And we can't memorize. We don't have time to do that here today. But in the future, you really need to memorize how these camera views are looking anatomically at the heart. And it gave you a nice slide to figure that out. You print out a normal EKG, and then you print out that slide, and you just look back and forth and back and forth. And believe it or not, your brain eventually is going to memorize what lead looks at what area of the heart, for sure. So right now, the name of the game is, I'm telling you, this is relatively normal or unremarkable. Yes, you can find some stuff wrong with it, but right now, I'm not terribly worried about activating a cath lab, screaming for a cardiologist. Right now, this patient's origin of issue, it's less likely that it's something to do with their heart, okay? But this is relatively normal. We wouldn't do anything in EMS on this. We would say unremarkable. Let me check I can't see that clock, Casey. What time are we at? 2:13? All right, 2:30, 2:30, trust me. I know this is a lot, catch your break. All right, so T waves. I cannot tell you how important the understanding of a T wave is in whether or not it's supposed to be a certain shape in a certain lead. So ST segment elevation or depression. What does depression mean? What is it when we see ST segments that are depressed or flipped? Low on what? Oxygen, right? That really is it. Majority of the time, it's an indication that we've got a patient that is presenting either globally throughout their body or just in the heart itself, low on oxygen, right? If you're in respiratory distress from pulmonary embolus, a massive one, and you're low on oxygen, it's probably going to show up in the EKG after a while, right? So V1 to V3, both septals into the first anterior can show elevation of 2 to 3 millimeters of ST segment elevation if you have LVH with strain. Now, our congestive heart failure patients out there, when they're starting failure, does that increase the amount of strain on their heart? Yeah. Would it increase the amount of voltage? Yeah, because the heart rate is going faster. Elements are coming in and out a little bit faster. Rapid ventricular response from AFib, right? We give a calcium channel blocker. What are we trying to do by giving a calcium channel blocker? Slow the rate of what down? The ventricles, right? They're going way too fast because of all the atrial fibrillation. Think back to your your bucket, right? All the elements that are in there. You're trying to block that calcium because way too much calcium is getting in there right now. And it's all starting with the fluid buildup in their lungs, and they're trying to get oxygen in. Everything's working harder, okay? So if you look at that 12 lead and you say, oh my God, they've got 2 millimeters of elevation, you may say they're having a heart attack. They're not. All you have to do is get that cup under control via the oxygen, maybe put them on some CPAP, some nitroglycerin, and guess what's going to happen to that voltage? You control the rate, you control the voltage in these cases. Now, I'm not saying it can't be a brand new MI under there, for sure. However, before you do an EKG on a AFibber that's in distress or a CHFer and declare it to be an MI, make sure you think of the cup. And is there a rate issue right now that's creating this elevation? Normal elevation looks like this, okay? The second one. ST segment elevation is indicated by, what's this point? J point, right? This elevation point right here, our J point. Here's our J point here. Here's our isoelectric line. It's an imaginary line that you can't see on the EKGs here and here, but you can see it here, right? So when you're looking to see whether or not there's elevation, I'm telling you right now, sometimes these EKGs can play tricks on you. If this P and R area right here, if this P to R, if that starts to dip down early and causes this to come down to here or go up higher, and you don't actually take the 2 seconds to draw a line before the P and T wave, you may at first glance think you're seeing ST segment elevation, and you're not. You're really seeing PR depression, or I should say you're not seeing it because you're not realizing, hey, I got to draw that line. And I've got some EKGs down the road to show you where that really sticks out. But this is the J point here, low on oxygen or depression. Elevation, we got to figure out why the 3 buckets. And then this one looks just fine to me, okay? Normally, your T waves shouldn't look like this, right? They shouldn't look like this. So here's your J point right here. Would you say that is elevation off this line? Remember, I said it was imaginary. In EKG, you got to draw it yourself. Before, after, or after and before right here. I don't see this point dipping down. That notch is what I'm talking about. That's actually a Q wave right there. But that point right there, if I saw that dipping down, I'd be worried. It's not. Stopping right there, going to here, I can rely on this. Definitely elevation, right? 1 to 2 millimeters. This is depressed, or also known as a strain pattern. This point right here, right? And this point right here. So there's something going on. That's not normal. This one, here's your J point here. It's lower. There's something going on. That's flipped. I know it's definitely low oxygen or subendocardial ischemia. And this one right here, your J point's here. Your isoelectric line would be down here. It's up. It's elevated. And then this one right here, I think we can all agree by looking at that saying that doesn't look normal, right? I would say it was elevated. I would also say that it is convex in shape, meaning, watch my mouse, it is more circular on the top. More circular than it is this. See this? This is more like a half drop in like this. This is concave. And this is convex. Those are 2 geometry terms there. Shapes, okay? Convex with ST segment elevation in your T waves, especially the precordials, should be more suspect for something very bad, okay? And then this last one here, is there ST segment elevation? Sure, there's the J point. Here's where our isoelectric line is. I don't see anything to fool me over here. That's 1 to 2 millimeters. But now I look at this T wave, is that convex, like this, or is it concave, like that? It's concave, isn't it? Or smiling. When I'm smiling, terrible things are less likely, I think, right? I think. I smile a lot, even when I'm cranky, so don't look to me to try and figure out whether or not I'm having an MI. But yeah, it's simple as that. I would look at this right now and say, I still got to run this by the cardiologist, right? Because they asked for a 12 lead, but I'm looking at it thinking, huh. And if I'm talking to them on the phone, I'm saying, you know what? These T waves are concave versus convex. They're going to know exactly what you're saying if they can't see the 12 lead yet. So symmetry is key. Symmetry is key in T waves. And it is so easy for you to take a pen and just cut a T wave in half and draw some lines to the left and the right like you see in here and trying to figure out whether or not they're symmetrical or asymmetrical. Asymmetrical in a T wave is normal, right? Or less likely for MI, less likely. This is medicine, nothing's exact, you know that. Symmetrical, this is bad. They're not supposed to be symmetrical because the repolarization and depolarization processes are on timers, right? So when the ventricle gets done and then the repolarization process kicks and starts going this way, you should see a T wave like this and then a drop off. Now let's start to prolong that issue because there's stuff going on. And now we're gonna see a smooth hill forming versus that abrupt drop off. Capiche? All right, so if you see this starting to lift up, this is a bad sign, or the handkerchief coming straight out of the box. Symmetrical, but growing and growing. Eventually, if you're doing repeat EKGs, you're probably gonna see some J-point lift, some ST segment elevation out of that. All right, here's some more examples of T waves. So we've got asymmetrical right here. I'm not as worried about this one as I am these. Now, there's different stories being told in these T waves, right? So we got negative here, low on oxygen. This, I'm not as worried about. This one I'm worried about, right? Even though I don't have ST segment elevation, it's tall and it's peaked. It's almost as big as the R wave next to it. What kind of patient are we worried about as far as the cup, the elements? Too much or too little is something here. What kind of patient are we worried about? Hyperkalemia, yeah, hyper-K, usually it's our dialysis patients that wind up in this calamity, right? Or rhabdo, or anybody that's got high potassium issues going on, for sure. That can be revealed in this. Now, this one's tall, but it's broad. It's a little wider on the bottom. So we shouldn't be thinking hyper-K with this. We should be thinking this is an MI that's potentially growing. And if they're very broad, obnoxious like this, we should start looking at them going, did I do a mend or a race exam on them? Do they have any reason for intracranial shift right now? Because wide, bizarre T waves like that are usually positive for CNS issue. I've got some more down the road on that. Don't worry, you don't have to jot down too much on that right there. All right, let's see where we're at time here. All right, 2:22, we're almost there. All right, so let's jump right back into STEMIs a little bit. And I like to review this with audience participation here when we have the cases up here. So I've sat on the STEMI review committee and my co-partner in the PI department, Warren Brown, has sat on it the last few years. And I can tell you these have been the most common culprits for EMS false activations. And guess what? Sometimes physicians have false activations too in our brother and sister EDs across the way. And sometimes our own physicians will have a false activation. Did I say that? This is being recorded. Mike's back there saying, yes, Dave, don't say that again. The same thing happens. They don't always see EKGs in the ED. Not every single day. Sometimes they'll have an entire shift where they're going to do nothing but cold and flu, hopefully not COVID, most likely some kind of COVID, right? They're not going to see EKG. So the same thing happens to them, right? A mind is a mind is a mind. It is what it is. But these are the top 10 here. So I'm going to see if you guys can throw out some other ones there for me. I'll start with artifact, number 10, reason why, out of the top 10. What else? What else do you think is a reason for a false activation? Pericarditis, absolutely. What else? Keep saying them as I'm going down. Number 9 is usually hyperkalemia. Oh yeah, LBBs are up there. AFib, A-flutter, absolutely will fool a monitor, which will fool you into thinking it's correct and saying it's an inferior MI. Right bundle branch block along with left, sure. How about a post-arrest ECG? What drug do we usually have to give? Hopefully we don't, right? Hopefully it's somebody we witness within the first 3 minutes. We got a 74% chance, if it's a shockable rhythm, to bring them out of it, right? True, false? It's true. I wouldn't be making that up. So cath lab, rehab, up on the floors. You know where your AEDs are. The faster you get it on, that's a true number, 74%. We don't get happy excited in the back of the truck when they go right into a VFib, especially with a STEMI patient we're transporting. But at least we know we got our pads on. All we got to do is reach over and hit. We got a good shot bringing them out, right? So post-arrest, though, it doesn't always work like that. We got to give a drug usually to help with the whole ROSC process. And which one do you think that is? Epi, right? And epi, what does epi do? A lot of things, but specifically to the heart rate, what does it do usually? Jacks it up, right? So if you think your first 12 lead EKG that you've done after you've just brought somebody back up on the floor in a living room or in the back of the truck is going to be reliable, you're a fool. Give it a minute or two, right? Let that epi work through. Pacemaker, if you're not really good, if you don't have the Medtronic rep standing next to you to verify this stuff half the time, they can be very, very difficult to determine whether or not the elevation you're seeing is truly an MI. Benign early repolarization, BER is a big one. Third is left, and then pericarditis, which we heard earlier. And the number one reason for false activation is the opercordial leads. 1 to 2 millimeters, usually with LVH. The machine's gonna call it. They get these right, about 75% of the time. I don't care what kind of machine you got. The algorithm is 75% reliable. Inferiors, it's 95%, okay? All right. So what is it? Out of the top 10, I'm gonna show you 10 examples, and you're gonna tell me what you think this one is, okay? What you think this one is. What do you think? You see that elevation, right? My eyes just go, woo! Oh, look at this big elevation here. When I made a mistake, I should have started here in my high laterals. And I keep wanting to look over here, look over here. I'm forcing my eyes. No, don't do it, don't do it. Stay over here. Get your inferiors. Now I'll go to my septal. Now I'll go here and I go, whoa, look at that. That looks like elevation. Well, we just learned a lot about T waves, didn't we? Would you say that that was smiling or frowning or convex or concave? It's more smiling, isn't it? Right? Or I really like it when people memorize the word concave, right? Because when you relay that back to a cardiologist, they're going to understand what you're saying. And then I look at this and I go, yeah, there's that elevation again. I got almost like, oh, look at that. Would you say that that P wave is going down as far as its P to R interval? Sloping down? Yep, another reason to start suspecting a different one of our buckets, right? But yeah, you got it. 1 millimeter or more, sure. 2 or more contiguous leads. V3 is contiguous to V4. Sure, ring the bell on this one. Guess what's gonna happen? Well, you're gonna get, hey, too much artifact. Too much artifact in this. This is a true false activation. Patient was shaking, leads were on, they were homeless, had 5 layers of clothing on. Not optimal. The ER EKG is perfectly clean and has slight elevation, but then you put the line underneath there and you can see easily that it's not true elevation. All right, how about this one? Whoa, does that look normal? Remember the baby, not just the baby, but the EKG that was tied to it. That's normal. Did it look like this? Heck no. Even if you don't know what you're looking at, you need to at least go to somebody else and phone a friend or get a physician's attention on this one. What do you think it is? Definitely not a STEMI. That bucket's out. Who says hyper K? Round of applause. Well done. Well done. It is absolutely hyperkalemia. It is absolutely hyperkalemia. So let's look at these T waves. Let's look at these ones down here. Now, they are broad. I hear you. However, so is this. The QRS width is a little bit wide on this. Very tall, right? Very tall. Now, there's something really cool here down in lead 2. And this is why you cannot, when you're looking at your patient, don't just get a 12 lead. Get a 6-second run of lead 2, right? As well, that's what I should be saying. Because there's something in lead 2 that also tells me that it's hyper K. Can you tell me what it is? Or actually the absence of it. I know some people just want to go, it's junctional attack. No. Yeah, you're right. Kinda, not really. Kinda, not really. There's no P wave because your atria are polarized. Why? Why are the atria literally frozen right now? Well, think back to the cup. That cup is full of what? Potassium. A lot of it. And when you got too much in the cup, guess what can't come in or out? Anything else. It's clogging that cup up, which means it's clogging the whole process up. This is why high elevations of potassium are so lethal, And I'll tell you what, the higher it gets, the easier it is to see the changes in the EKG. You don't need lab results, man. Nope. You look at that and go, yep, I know what's coming right here. Serum potassium of 8.5 to 9, you're easily going to be able to interpret this one real quick, right? That's our good old friend asystole. That's asystole. Now, is this VTach? Is this ventricular tachycardia right here? No, it's on a potassium slide, so obviously it's not, right? But if I didn't tell you this was a potassium slide and I told you something like this, and you forgot that the patient in the bed or in the home or on your stretcher was a dialysis patient, you look over immediately, they're unconscious, you look back at the monitor, it's dinging, and you see that, what are you most likely to do? Shock them. Is that going to do them any good? No, that potassium is just going to go, woo, thanks for the electricity. It is going to be of no benefit to you whatsoever. So I got bad news for you that just took ACLS classes. It's not that easy. It's absolutely not that easy because this needs stuff to get the potassium out, like bicarb, albuterol, calcium, right? Calcium, all that stuff will help us get the potassium out of the cells and at least poof, out into the bloodstream. Body's going to have to take a lot of fluid to get the rest of it off, right? But this is huge to know this, that you can actually see elevated potassium in there. All right, which one is this? And then we'll go to our first break. All right, so potassium is out of the way. Artifact is out of the way. Is it fast? Are MIs usually fast? No. Take a look at that run of lead 2 again. Something look weird about it? Take the R waves out visually and just look at those P waves and run it straight across the bottom with your eyes. What does it look like? Look like a saw? Absolutely. These are F waves. These are F waves tied with atrial flutter. Atrial flutter. So there could still be an MI in here and they could be in cardiogenic shock. That's least likely, right? Unless I hear from my patient, increased shortness of breath, chest pain on and off for 3 to 4 days. Why didn't you call the ambulance? Because I don't know. I didn't want to go. Then maybe I look back at that EKG, but still I got to control the rate. I control the rate a little bit. Right? And then I look at that EKG again, but the machine gets fooled because it looks right here, right? It says, oh, that's the J point. It's not, it's an F wave building onto this. And you see, it's not your traditional 2-to-1. It's a 1-to-1 almost. It's going fast, but that's actually AFib. All right, one more. I lied about that break. One more, and then we'll take a break. All right, if you look at the top, it's a strong hint of which one out of the 10. We said artifact. We said, what was the last one? AFib, aflutter. We haven't gotten any of the bundle branches yet, so it's not that. I talked about waiting until this drug works its way through before you say yes. So you think you're seeing ST segment elevation over here. So these are actually PVCs, right? And it looks like we had a run of normal with something else. It's really confusing. I would definitely not go, wow, that's ST segment elevation, that's ST segment elevation. And then these look like PVCs too, right? So this needs to calm down. This is an irritated heart, especially after I just brought him back from the dead. This is a post-arrest EKG. All right, how does 5 minutes sound? At home, you don't have a choice. The audience is going to pick for you. 5-minute break, then we come back. Is that enough to stretch? Okay, I'll give you 8 minutes. Those of you who want to walk up and down the hall. Let's take a look at the clock. The clock is 2:34, so we're coming back at what time? 4 plus 8. 2 carry the 1, 48. I will see you at 2:48. 2:48. Please at least stand up, and that's you two at home. Get up, walk around your office. Stretch your side. My left side of the room says yes. Right side, what say you? Yes? All right. All right, let's get back at it. I'm going to throw the next EKG at you. Here it comes. Out of those 10, which one do you think this is? Which one do you think this is? So it's not AFib. I know some of you are going to say artifact. We already had it. There is some artifact in there for sure, and I would redo it. But it was activated off of this. But this one is not actually artifact. I have heard the term bundle branch block, and now I'm hearing specifically a right one, and I probably would agree. This is a right bundle branch block. Gets confusing again. People just look at it and say, I don't know what it is, must be a STEMI. Well, I got a little secret to share with everybody in virtual world and everybody in the room here. Most of the EMS folks that have known me for at least a few years know that when we started the STEMI program in this region, and Claire Corbett and the team inside the hospital threw it in play with EMS, guess who had the very first false activation in the region? You're looking at them, and it was a right bundle branch block. Guess who didn't have a false activation ever after that? Yep. Claire pretty much just looked at me and said, it's okay, Dave. It was only the first activation of the whole program that we all worked so hard together to throw together. And Don McLam was the ED physician, and it was literally his first day on the job. He had no idea what he was looking at either when I handed it to him. He said, okay, it must be. Boy, was he mad at me. But that's all right. We get better. All right, here we go. So the golden rule on bundle branch block and paced rhythms. Now, you can apply this for paced rhythms. Try and figure out whether or not out of the 3 buckets there that it's really coming from an MI if you understand this. Now, there's lots of criteria out there. You got Scarbosas, you got this, you got that, you got the Cleveland way, the California way, the Los Angeles, I don't know. Just stick to this, right? When in doubt, ask a cardiologist for sure on the inside. But just know this, at first glance, it is supposed to look like something, even when it's a normal bundle branch block, okay? So follow my mouse here. Where are we? Here we go. All right. So forever, a bundle branch block that is not brand new before your eyes, AKA the patient says, I have a history of a right bundle branch block. It should look like this, discordant, meaning the R wave and this T wave should be opposite of each other in certain leads. This deep old S, right? This R, this complex here, this is technically the R, but this S and this T over here, they are discordant, meaning they are opposite. Now, when you look at that same patient who said, yes, I have a history of a left or a right bundle branch block, and you start looking at their leads, and you start seeing what's called concordance, meaning they're both heading in the same direction. Let me have your eyes and your brain again. I am telling you, this is normal for right bundle branch block, left bundle branch block, or even certain types of pacemakers. But let's keep the pacemaker out. This is enough right now. Left and right bundle branches. This is normal. This is not. This is absolutely not. Okay, you want to call that discordance, but look, they've gone to all the trouble of putting the word up here for you. It is concordant, even though this is heading in this direction, negative here, that is not supposed to be there, or what we call the terminal portion of your QRS, the pointy thing, right? Tell your brain now to think, if I see a pointy thing going down in this direction in a bundle branch block, and then I see this next to it, that's not normal. Not for that bundle branch block patient, okay? This is reason for you to start thinking, this is an MI. Let me show you one in action, okay? You are looking at a bundle branch block. Which one? Right, okay? We know that it's a right because we look up the V1 and we go, is this a positive or a negative? The old turn signal thing we're taught, right? You flip up, you're turning what direction? That's my right. You flip down, you're turning what direction? That's my left. Okay, so same thing here with V1. If it's positive, I'm flipping it up, it's a right. If it's negative, I'm flipping it down, it's a left. Now, a lot of people want to ignore this machine. You want to ignore it on your interpretations. I get you. The machine needs you. Guess what? You also need the machine for certain things. And one of these things that these machines are really good at is measuring things that our eyes, especially in the middle of the night, 3 o'clock in the morning on the floors or in the house or in the back of the truck, versus 3 o'clock in the afternoon. Even if you're a night shifter, it's going to be a little more difficult. Let the machine count the boxes for you, especially when it comes to the QRS, the QT, and the PR measurement. Now, what's the QRS measurement on this? Point what? 1, 2, 4. What's my parameter for a bundle branch block? What's that at home? Oh, somebody just telepathically sent this to me. All right, that's how good I'm getting at this Zoom thing. 0.12. 0.12, and if you've never written this down before or heard this, write it down right now. 0.12 to 0.14 bundle branch block. And then next to that, in parentheses, I want you to put 0.14 to 0.16 VTAC. If you look at a lot of these algorithms, including the state of North Carolina and almost every EMS agency's algorithm for treating wide things, it specifically says on it, or in it, it mentions the number 0.12 as VTAC. Incorrect. We do not need to be cardioverting left bundle branch blocks. Okay, that's why it's important to remember those widths. So 0.12 to 0.14, I'm thinking bundle branch block. So I look at this and I go, all right, it's a right. Do you see any leads with that concordance thing that we just talked about? Okay, so I'm going to start my high laterals. No, no. Discoordinate, discoordinate. How about this? Okay, so here's my J point on this one. That point. What did I tell your brain to remember on the last thing? Let me bring it back. I told you to remember this, right? Okay. Does it look like that? Sure does. You're witnessing live and in action. Terminal point right there. This is not normal discordance. This is bad. Reciprocal change, absolutely. This is also telling me ischemia. Same here, not as prominent of a point as that one. Same here. All right, now how about V1? Are these two heading in the same direction? Heck yeah, and it looks bad, right? It looks, from everything we just talked about T waves earlier, that T wave looks problematic, right? This does not look benign at all. How about V2? You see the same thing going on? Yes, remember, this is a bundle branch block. Patient tells us, yeah, I got a history of a left or right. Now we're kind of looking at it going, okay, well, that doesn't look like a normal bundle branch block to me, because I remember this concordance rule. These leads are kind of supposed to be looking like this, right? Positive and negative opposing. They should not be running together with these T waves and these R waves. Now, I'm not telling you, you call it, because the criteria is the criteria. But you call a friend, you get somebody. You get somebody to take a look at this patient for sure. Especially if they're sweaty, pale, diaphoretic, and look like they're having a heart attack, right? Because you're supposed to be able to combine those two things together with what you think about the machine. And then the other thing is these little notches here. What are they actually? Right there. That's a Q wave, right? Here's another Q wave. And then over here's another Q wave. Another notch right here. That's a Q wave. When I start seeing multiple Q waves, what am I supposed to be thinking? Q wave, every single one of us has it, but there's not enough energy because there's not, the cup's perfect in that area of the heart, right? SA node to the AV node. Everything's going on. There's not enough energy to really produce a Q wave. There is a lot of energy, a lot more energy though, when you're having a heart attack. Okay, and that's why when we start seeing a bunch of Q waves pop up, this negative deflection after the positive deflection of the P wave, right? These are Qs. We start seeing this pop up. I've got concordance. I have got a bundle branch block with an MI. Absolutely. Those are all concordinates. We should be seeing discoordinates. That's a sick patient. All right, back to the 10. It should be easy for you, especially knowing you just looked at the last one. QRS on this is, what do you think? 0.12 to 0.14? Boom. Yes, it is. What is it? Up, up. It's a bundle branch block of some sort, right? Some of you have got to be seeing this little thing right here. Bum, ba, bum, bum. Bum, ba, bum, bum, bum. What do you think that little notch is? A pacemaker. Absolutely. Absolutely. I love this. I love when I hear this. Well, if the pacemaker isn't firing, there's a problem with that patient. Is that true? No, we don't do fixed mode pacemakers with every single patient out there, right? Ideally, we want to put demand ones in there because what happens to muscle when you give it continuous strong energy? Yeah, it starts working, develops a memory, right? Muscle memory, stops working on its own, forgets to do things, and it also becomes enlarged, right? So only the sickest of sick patients out there get a fixed pacer. That's why even in the EMS world, we pace in demand mode. We only go to fixed if we have to. All right, so this is a paced rhythm right here. This is a paced. Looks just like a left bundle branch block. And it's going to produce pretty much the same thing unless you are smart enough or quick enough to catch these little notches and you remember what those are for. But you look at that at first glance and you think, well, yep, that does not look like that baby EKG, the normal one for sure. That just doesn't look right. And then you see the pacemaker spikes. Don't try and figure this one out. Ring the bell if they're extremely symptomatic. Get your labs, EMS, take them in, make the phone call, say, hey, I need a doc right away to come over. Just stay away from it. Follow your criteria, two or more leads with 1 millimeter or higher, except V2, V3, something like that. V3 before, I don't know. We got to have 2 millimeters in those, yeah. All right, so those are the pace notchers right there. Okay. All right, the last one was a pacemaker. Which one do you think this is? Huh? Yeah, left bundle branch. Okay, QRS is looking right at it. Looks pretty big. Doesn't look bigger than 0.14. I look up the V1 and I go, yep, it's pointed down. And then I look at, here's a bonus for you. I look at lead 1 and then I look at V6. And if these are both positive, like they're supposed to be in a left bundle branch block, because that high lateral and that low lateral, where they look, the energy is now going away because the left side's blocked. I know this is a lot to take in right now. If they were opposing and I had an extremely symptomatic patient with this, even though I didn't see concordance in any of these leads, which I don't, right? I would still be suspects that something's going on because they are not supposed to be opposing, meaning that would be positive and this would be negative. If they're opposing, you may be seeing the birth of this patient's left bundle branch block, if you know what I mean. LAD occlusion with cutting off the entire LBB, okay? But that's super advanced. Just want to point it out that you can see that kind of stuff even further. And the right bundle branch block is supposed to have slurred S waves, which obviously this isn't right, but you look in the same leads, 1 and V6, and if you have slurred S waves, you know it's normal. And if you don't have slurred S waves, they start coming straight down instead of going off to the side. Be suspect that that's a brand new right bundle branch block growing before your eyes. All right, how about that? Does not look normal, does it? Heck no. I see a lot of what? I see a lot of ink. And when I see a lot of ink, I start to think, out of my cups, I got a voltage issue going on, right? Or LVH, right? But I see more than LVH here. Is there a bundle branch block? The QRS is 0.12 for sure, right? Look at this. Let's count the boxes. There's 1, 2, 3, 4, 5, 6 little boxes. What does that make? What do they represent this way? 4? 0.04 in width, right? 6 times 4 is, so 0.24. How's that sound to you? It's wide, okay? So it's a bundle branch block. Bum. Now, do you see concordance in any of these leads? Is that going in the same direction of that as that? Yes. Yes. Right? So I'm highly suspect that within this left bundle branch block, there is an MI. Look at this, V6. Just looks like a good old ST segment elevation, and that does not look concave. That looks way more convex. The J point here is right there. Even though, yeah, I hear you on the discoordinates, the good old-fashioned stuff still applies. That shouldn't be elevated that high. I'm definitely getting somebody's attention. Definitely getting somebody's attention on this. So we got left bundle branch block with strain, right, with LVH, and concordance in this left bundle branch block. This is a bad day. How about this? We're almost done with our 10. You're doing well. Now, definitely look at every single lead here. Your high laterals, your inferiors, your septals, anteriors, and our what laterals? Low laterals, right? Low, okay? And then even take a glance at your run of lead 2, because that has some value added. If you just kind of look at it, run your eyes all the way across, you can see something's going on, right? In 2. What do you think? Do you see something in almost every single lead? I hear a over here. You concur, right side of the room? You see something in almost every single lead catch your eye? Is there a J point issue in almost every single lead? Do you see what you think is just slight elevation? I see some heads going up and down. I'm sure at home, where you guys have your screens directly in front of your face, you see exactly what I'm talking about. Now let's go up here to AVR. Remember this lead? What does AVR look at? Everything, right? It can see everything, but not that strong. So let's look at it and say, well, it's not going up right. So I know we don't have an override energy coming from the bottom of the heart flying up to the top. So it's not VTAC. Nobody here should have been thinking that. It is going in the direction that it's supposed to be, but AVR's got a J point just like everybody else does. And look, that J point is right there. Isoelectric line would be up here. Would you say that was depressed? Yes, sir. Yes, ma'am. I've got a global ischemia thing going on, according to what AVR is telling me. And the entire heart almost has got some kind of issue, because every single one of these leads has got some form of ST segment elevation. Now, if you bank that J point, you bank that J point there, yep, you're going to have it. You can call a STEMI on this all day long. Would you be correct? No. You'd be coming to see me. We can do a little bit of review, because this is absolutely going to be pericarditis. Global issue. Remember, the pericardial sac, or you can have endocarditis, kind of triggers this 12 lead too. It is what? Inflamed or shrunk? It's inflamed, right? Anybody ever here see an image or actually see a heart that has pericarditis when they cut the sac to relieve some of the pressure? Wow. It's easy to see why they can become real sick, hypotensive, real fast, and why not all the time they have to be trained, but it can be very, very problematic for them. And the same, you're going to see the same thing in the EKG. It's going to look like they're having a heart attack all over the place. You only have a couple of coronary arteries that are broken down into a few other smaller divisions of those coronary arteries. It is impossible for you to have ST segment elevation in every single lead and be living, okay, during an MI. All right, here's another one with nice arrows to point out everything that we just talked about. A little more obvious in this one. Again, the questions I want to ask this patient, believe it or not, the dental office, right? You got good bacteria in your mouth. When you have dental work done, you can push that good bacteria. Or if you're coming from the north or the west and move into this area, there's bacteria. There's mold growth that your body may not necessarily be used to. We do have not too many, rare case, but just moving from one area to the other on the globe, you have an increased chance that you can get an infection in your heart. Vegetation starting to grow in your valves, not a good thing at all. This is what your EKG is going to start looking like. When they lean forward, their pain usually changes, right? Because you're changing the thoracic pressure gradient. They lean forward, they push, it muffles, squeezes down on the heart and helps hold it still so it's not going ba-boom, ba-boom, ba-boom with swelling. That's why it feels better for them to lean forward. Okay, recent visit to the dentist. Have you just relocated here? High fevers and an EKG like that? I'm thinking they've got a pretty bad infection. All right, coming down to the end. All right, so I'm looking here. I don't see elevation. I see a flip T wave, but that really doesn't look asymmetrical, that's for sure. It's going like that, and it's kind of going back at a sharp angle there. And there, same thing, V1, V2. All right, so I've got ST segment elevation there, but I've also got an R wave popping here. Usually in MI, you don't see an R wave right there. You don't. You really don't. And then here, look at this S wave drilling directly into this R wave. Isn't there usually a decent space between these two? Yes, right? So my eye is starting to say, wow, we've got an increase in transmission, increase in voltage on this patient, right? Same thing here. This S coming down, running directly into that R wave. And then this is flipped. And sometimes you'll get the, be like, oh, let's see, I've got it. I've got my criteria. It's barely 2 millimeters. They got 1.5 millimeters. You follow our criteria, though, you can't call this unless it's 2 or more. But then I go, well, this is a reciprocal change. Is that really a reciprocal change? It's flipped, but it's asymmetrical. I'm looking at that T wave, and then it just doesn't look like my typical flip T wave. And this too, they're going to call that a reciprocal change. This is a strain pattern. This is more or less a strain pattern that you usually see with LVH. It's not a reciprocal wave, it's actually a strain pattern. So your simple formula, this one is a little more obvious than this one, right? Let's go back. That's what I like to call clean LVH. But anytime you start seeing complexes run into each other or ink running off of the paper, the 12-lead machine will actually crop it. It's going all the way down to the bottom and it's not going anymore. You should start thinking there's a voltage issue here. I'm not telling you people with voltage issues don't have MIs. I'm just saying it's less likely that ST segment elevation you're seeing is actually coming from an MI. Don't you love how clear I am? Welcome to medicine again. All right, so same patient, a little faster of a heart rate, right? We're tachycardic. So look at that. That is a nice, clear strain wave right there. That's a strain pattern there and there. And sometimes you can see them over here. But you got this big progressive R wave over here. You shouldn't see that. And all you got to do is add up some stuff to figure out whether or not this is LVH. Okay? The easiest way, hold on. Sorry, I'm zipping back here. Get back to this. The easiest way to do this is you pick the bigger S wave. If you don't know how to do this, jot this down. The bigger S wave between V1 and V2. Okay, so it's going to be V1. And the bigger R wave between V5 and V6. So that one's going to be the bigger one. Now you count the boxes. Okay, I want to make this easier on you, though. But you got to make sure you remember how many boxes are in the big box. Okay, so this one here, I can see this a little easier than you can. So we got 1, 2, 3, 4, 5, 6, 7, 8 or 9 roughly. And then this is going to be, so these are big boxes. There's 5 little boxes to a big box. Everybody remember that? 5 by 5, 25, something like that. 5 by 4, which is it? 5 by 5, 5 by 4. What's 0.20 is normal for one big box. Anything bigger than one big box between the P wave and the R wave, we're supposed to be thinking first degree block, correct? So it must be 5 and 4. All right, so 1 big box, 2 big box, 3 big box, 4 big box, 5.5. How many millimeters is that? 5 times 5, 25, plus half, 26, 27, 28, 28 plus 8, 36. 35 or more, you've got LVH. 35 or more, you've got LVH. So you add up the larger of V1 and V2 S waves with the larger of V5 and V6 R waves. Add all those little boxes going up and down together. If you come up with 35 or more, you've probably, most likely, got LVH. All right, so it's easy to see this is a bad day for this patient right here, right? We've taken a slice of the heart and it's not in the heart anymore. So this is a bad day. We can see a very active MI probably, and well, it's not active. It was very active at one time. We see a deteriorating septal wall. This left ventricle right here is actually enlarged, okay? It's enlarged. There's more muscle than what they're supposed to be. The hole's supposed to be a little bit bigger here. So this kind of EKG, especially during this heart attack, I would expect they would have had some voltage issues showing up on their EKG. Make sense? It takes longer for the energy to travel through that enlarged left ventricle than normal. So that's what you're seeing on the EKG. All right, nice picture of the, especially with these, and hold on, my smiley faces that are coming up. All right, so right here, again, is it concave up like this? Yeah, you've got elevation, but is it smiling, frowning? And is this asymmetrical or symmetrical? These are not even. Everybody agree? Simple geometry. That is going down one angle. That is clearly not even to the other one. It's going another way. Less likely that this elevation is coming from an MI. Smiling, right? Or concave, right? Concave. There's still ST segment elevation there, but it's less likely that it's coming from an MI. You're going to fall into that false activation pit. And this one, it looks bad, doesn't it? Do I really need to draw that for you? You can see this is clearly the J points right here. You've got what, 4 millimeters of elevation. That, would you say that's pretty symmetrical too? That's like almost a perfect mountain forming, right? And then this part right here is definitely convex, right? Way more convex. Not frowning, or I'm sorry, not smiling, more or less frowning, right? This is pathologic. This is a bad day. All right, last one, which is it? Last one. Out of all 10 of those, we've talked about bundle branch blocks, we've talked about pacemaker, we've talked about AFib, A-flutter, we've talked about LVH, we've talked about post-arrest EKGs, we've talked about pericarditis. What's the last one? Benign what? I thought you said you're lying. Not lying. Benign? Benign. Benign early repole? Survey says? Well done. Well done. Absolutely. You see the elevation there? Sure you do. But let's look at the left first, right? Let's look over here first. My high laterals. I'm going to roll through. Whoop. That looks like a little elevation. Look at that. PR depression. Dun, 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 dun. Draw the line, and you'll see what I'm talking about. It's not really elevation. It's biphasic, right? So I'm just going to skip past that. Again, I see elevation. No, you don't. You see PR depression. That is going down at an angle. So if you draw that line, quick line right before the P wave and the T wave here, you're going to see there's no elevation. The P to R depression is playing tricks on you. All right, so J, yeah, all right, so I'm going to go here. All right, I see this elevation. J point's right about there. Is that smiling or frowning? The smiling, right? AKA convex, right? Or concave? Concave, very good. You're starting to get it. Concave. That is concave. Less likely it's coming from an MI. Is that T wave asymmetrical or symmetrical? Take your eye, start here, draw a line straight down through that part of it, and then draw a line off to the side. Hint, hint. Is it asymmetrical looking or symmetrical? Asymmetrical, right? More in the benign category, okay? Same with this. And then what did I say about the R waves being in the front like this? Usually not in these V leads. And that R wave is getting bigger and bigger. I'm literally starting to see a backflow problem with the energy here and with the repolarization process here. You are seeing the heart repolarizing and almost overwhelming the contraction state. It's benign early repolarization. Some strange reason we're firing off a little bit stronger than we should be when we are getting set to do it all over from the ventricles on up. Make sense? Good job, BER. All right, clear your minds of STEMI. Clear your minds of STEMI. Let's get into some unique cases here. Unique cases. I go for an apple. I like a good green apple. You guys like green apples or red? A little rough on my teeth sometimes. I don't, biting into them. But I definitely like the greens better than the reds. I'm probably a little more sour than most. Nobody's laughing. All right, some giggles. All right, so I'm going to give you the case example. I'm going to give you some hints behind this, okay, with each one of these, and we'll see if you guys can figure out. All right, is that normal? Think about the baby EKG. No, this is not normal, okay? Definitely not normal, but do you think it's a MI? I see the ST segment elevation you think you're seeing. All right, so let me give you some backstory on the patient. Let's say this is a homeless patient, so that EMS and hospital providers can understand this, but the homeless patient has been sleeping outside of Cape Fear Heart's building for a week. And the staff have been going out, giving some lunch, some food, because they feel bad for the homeless patient. Patient disappears at night, comes back. Well, it's getting colder outside, and that homeless patient is spending a little bit too much time sleeping outside of Cape Fear Heart with just a little bitty blanket. And then you come along and they're completely unresponsive, and you take an EKG, they're breathing, right? Slow. Their heart rate is slow. And this is the kind, and they're not able to respond to you. And this is the kind of EKG that you get from them. So now what do you think? Do you think heart attack, or do you start thinking some other things, especially because of the environment? So you want to look at this and go, well, that's ST segment elevation. Have we seen a point yet? And any of these J points, that point thing, it's almost like that terminal thing that we see down here with something completely different from this, right? But you got that weird looking point where you think you're seeing an ST segment. It's actually delayed. That's why that point is there. And there's a run on lead 2 down here. And the P waves don't look like they're firing well, but they're firing. But it's bradycardic, right? It's definitely slow. I'd still call it sinus because I've got these P waves. But I'd look back at this patient and I'd say, man, how cold are they? What you're actually seeing is what's called J waves throughout this, or the Osborne sign. And anytime they get really cold, this patient's core temperature is about 76 degrees. Cape Fear Heart, why didn't you bring him in? It's a really cold night. Whoever closed it, they could have brought him in, let him slept in the lobby. No, I kid. All right, so this is what you're gonna see. You're literally gonna see this Osborne sign, and people will think, no, it's a heart attack, especially because they can't talk. No, think about your environment. Take a temp on them, get a core temp. They're bradycardic because they're cold, right? We rewarm these patients, and they're seriously sick when they reach this point, trust me. And that 12 lead is gonna change completely, and these Osborne signs will disappear. All right. Take a look at this one. It's fast, right? Look at your run at lead 2 on the bottom. It's at least 6 seconds. It's fast. Now let's see how good your brains are. You retained what we were talking about with T waves. Tall, peaked, wide, base, super wide. That's not normal. Definitely doesn't look like the baby one I was talking about. All right, so you want your patient information? Sure you do. All right, so you've got a patient in front of you who has history of suicide attempts, mental health history, takes appropriate medications for that mental health history, and is now unresponsive. And you find one of those bottles of medications is completely empty, And you look on the outside of this bottle and it says amitriptyline on it. And that's as far as I can go. What do you think you're seeing in this EKG? You can't answer. You cannot answer. Anybody know what amitriptyline is? It's a what? It is a tricyclic. Now, how do tricyclics work? Well, yes, you overdose, you die. That is correct. We try to get to you before that phase, right? Well, things start to happen, especially with your brain, right? Because that's where it's working to make things a little bit better, specifically with depression, but it slows things. Again, you got a whole nother cup up in your brain trying to do stuff. And this drug specifically, without getting in too far into the weeds, actually will start speeding up things like your heart rate, okay? However, look at these T waves. How's that look? I got a little issue going on here. Does that look wide and smooth? So remember the cerebral T waves I was talking about before? Like, I'm not getting any power off this plug. In the, like down there? I don't know how long my cord. Let's see what we got here. Thank you. It started flashing at me. I was like, what's going on? All right, so down here, look at that. It's almost like a melon scooper. All right, like you just pop some ice cream out with a scooper. Contact, thank you. So these are cerebral T waves, what you're looking at. And this right here in AVR is a biphasic symbol that you usually don't see. What this symbol all the way on the outside is seeing energy going in two different ways across the heart. Not normally like it's supposed to be, but not powerful enough to really cause calamity. So, and the tachycardic rate here. So if you see this bottle, you can expect this patient to be overdosed on tricyclics. And our treatment for this is going to be lots of bicarb, right? Lots of bicarb, ICU admit. All right. Does it look normal? No, it does not look normal. All right, you want the backstory? I'll make this one easy for you. 28-year-old ejected off of motorcycle, no helmet. What you think? What do you think's likely going on with the patient? What do you think happened when they got ejected off the motorcycle? Hit his head. You think they suffered what we call a TBI, traumatic brain injury from the impact? Man, they were flying. They were doing 70 miles per hour ejected and landed right on their head. Okay, you can see it in the EKG. Where is it? Do these look normal? Again, you've got this wide, bizarre T wave. Okay, and yeah, it's symmetrical, but this is a different kind of symmetrical. These are what you call cerebral T waves, right? Cerebral T waves. So the big reason why you'll see cerebral T waves will be a subarachnoid bleed, right? Subarachnoid bleed. The QT interval will also usually grossly be prolonged, super wide, 600. 600 will be the count, 600 milliseconds. And then we can see these cerebral T waves for other reasons. Not always. It's got to be pretty extreme with these patients for you to pop it out on the EKG. But we can see it because of hemorrhagic stroke. And then usually if it's going to be a massive, it's usually an MCA occlusion. It's causing edema, cerebral edema. So anything that's going to have any shifting going on in the head, especially massive, we'll probably see some stuff come up in that EKG. Not always, right? Not always. But when you see a weird one and you're dealing especially with somebody who's had a post-head injury up on the floor or EMS, if you got a brand new head injury in front of you, think those T waves are not because of ischemia. That's because there's something seriously wrong inside their head right now with the swelling going on. Okay? All right, wonderful, wonderful. Backstory on this patient, dizzy. Dizzy. Well, yeah, Dave, you can see that. Their heart rate's like what? 140? Dizzy. Dizzy, lightheaded. What you thinking? What are you looking at? All right, let me walk you through a little bit. So we'll start with our high laterals. I mean, for obviously the story, there's wideness here, right? So I'm going to look right at my QRS, and I see on that QRS 0.14. 0.14. So I'm like, okay, so I could just call the bundle branch block, and then I go, wait a minute. 0.14 is on the high end of the 0.12 to 0.14. So I'm going to look at this EKG just a little bit differently. So I'm going to look at 1 and 2, 3 or 2 and 3, and AVF. Well, first off, are my inferior leads supposed to be negative? No, that energy, those vectors usually fire off when everything's correct. I see positive complexes in the inferior portion, right? The way the energy works is I'm mostly seeing the front part, catching all the energy going straight through the heart, all the way through the middle. It's coming from the top down to the bottom at an angle. So that's catching my eye. That's interesting. And then I go to V1, it's positive. V2 is positive. It just doesn't look bad. It's not LVH, right? I don't see the energy bearing into each other on these complexes. V4, V5, V6. Man. And then I come up with the AVR and I go, huh, that's not supposed to be positive, is it? No, the know-all, be-all lead that sits out there that you've been told is useless has a role here too. And it is supposed to see energy going away. If it's positive, which direction is that energy going? To it, right? To it on that camera. So now I want to print a strip because I know I can't rely 100% on interpreting EKG stuff through 12 leads, because 12 leads are a tool for you to help figure out other stuff. EKG interpretation. Now, look, the greatest minds in the world can figure out timing and everything off of 12 lead and probably figure out a second degree versus a second degree type 1, type 2 at a third degree block. But I'm telling you, your life's going to be a lot easier if you just print a 6-second strip and don't try figuring it out with 12 lead if you're trying to figure out if there's a conduction issue, okay? 12 leads are great for figuring out unique patients in STEMI or no STEMI, or if they had a heart attack in the past, for sure. But this is probably going to be VTAC all day. But it's not so simple, right? We just talked about quite a few things in that 12 lead that can help you out. But the biggest thing is remembering, if you look at a run of lead 2 and you say, man, that QRS is wide. Okay, you rule out potassium real quick. Make sure it's not a dialysis patient because you know what's coming next if it's that wide. And you look at it and go, man, it sure does look wide. And I'll tell you what, your precordial leads, if they are all heading in the same direction, they're all negative, they're all positive, that's likely it's going to be VTAC too. AVR is positive. And then I look at this and I go, what? But Dave, these are not all positive. You're right. These are actually negative. And what an EP doc will do is they will look at this, go, the QRS is 0.14, blood pressure is not so great. I actually, because 5 and 6, where the low laterals are not really involved in this calamity, all the calamity appears to be more midline towards the septal wall. Well, guess where the little cluster of cells is causing all this problem? Right on the wall between the left and the right. So they'll know right from this where to go in a blaze, potentially if they have to go in a blaze issue, or they'll just cardiovert it, but they're going to know where it is. But most of the time you see everything heading in the same direction or everything heading in the same direction down. That's more support that it's VTAC. But I'm telling you, if you just print a strip, a long strip, remember what we said in the very beginning, no matter what, all these pacemaker areas, if they've got the right amount of elements to put in, don't worry, Suzanne, we're getting to the next break, a couple more minutes. If they've got the right elements to put in, they're still firing regardless, right? So VTAC, the ventricles, that little area down there. Oh, if you didn't know that too, you can have just a little area of the ventricles creating VTAC. It doesn't have to be both ventricles. You literally can have some kind of response coming out of the right side, a little bit of output coming out of the left. That's why not all your VTACs are on death's door. There are some VTACs, yes, it's critical, yes, they need to be fixed, but somehow by the grace of God, the Irish, whatever you believe in, they have a decent blood pressure, systolic 100, 110. Well, it's because that area of the heart that's causing the calamity is not really screwing with output. It will eventually. It will eventually. But if you print this out, you're going to see this stuff because eventually the other pacing areas of the heart win, okay? So you see this QRS that's wide, consistent like this, and then all of a sudden you see this right here. What do you think that is? That is what we call east meets west, or a fusion beat. The SA node got it off. The ventricle got theirs off, and they meet right in the center. So you've got this complex right here that literally looks like a little bit of SA action and a little bit of ventricular action, a little bit wide. Now, you see a couple of pops of these, you got what's called capture. Now, this is the SA node just getting one all the way in there, all the way down successfully. Your ventricular tachycardia is still there, but no matter what, if you print a strip out yay big, more than 6 seconds, you are bound to see some of these indicators in there. And now you know, yes, it's VTAC. You got all that evidence in the 12 lead. Plus you see these fusion or capture beats popping in between these long runs of VTAC. Looks like a duck, walks like a duck, quacks like a duck. That's a lot of evidence. I've just given you like 5 or 6 different ways to figure out whether or not it's VTAC. Don't you worry. It's an overclockable computer right here. Postpone. All right. So we're going to do one case and then we'll go to break and then we're going to go all the way home. We are supposed to run until 4:30. We may get out a little early, which means at home you may be able to shut off a little early, or we'll run right to 4:30, okay? What we're going to do is we're going to do first case, okay? And these are actual cath lab cases, all right? So I'm not responsible for how well these 12 leads come out. You got to deal with exactly what they were looking at. But we're going to say STEMI, no STEMI for these first couple of cath lab cases. And this, I'm going to show you the actual pre and post films, which really helps you understand where in the heart the issue was going on that you were looking at. Really takes it home. Tell me right now whether or not you would activate the cath lab on this. Meaning yes, I see some heads going up and down. Yeah, so high laterals, my inferiors, and then obviously right here is where I start pausing. I got my J point right there. And I know what you're thinking, it's smiling. Well, because this is so high up, I'm gonna teach you something else. When you start seeing it like this, right where your J point is where you need to, in your mind, draw a straight line across. That bottom part becomes irrelevant whether or not you're trying to figure out if that T wave is symmetrical or not. Okay, so if you're just looking above my pointer, above it, would you say that portion of the T wave is symmetrical or asymmetrical? It's more symmetrical, isn't it? Down here, it's asymmetrical, but when they start getting this high up where that J point is right there, make a mark on that 12 lead right there and look above it and say, is that symmetrical? Don't include this bottom part here. All right, I don't have a voltage issue. You see, this is not going into this complex. You just got to take my word for it. This is not cropped off on the end of the paper. All right, so I don't see a voltage issue for this. That R wave, it's progressing, but is it getting really big over here? It's about the same size. So I'm not going to say it's progressing. Nope, it actually goes down a little here. Okay, here it progresses, but that's not the leads I'm looking at. And I'm thinking probably, most likely, there's an occlusion in this patient. And yeah, they're very symptomatic. So what coronary artery do you think it is as far as the cameras go? Well, we know the V leads are mostly left, right? So now we're on the left ventricle. So do we think it's a left main? I don't know, because I would expect every single one of these to be lit up, or those high laterals to be lit up with something if it was an entire top of the heart all the way down. All right, so because the elevation starts here at V2, now I'm going to start thinking halfway down on the left main, which is what? My left anterior descending, and what is that little spin-off called that goes round the back on the left? Circumflex, right? Okay, so now I'm thinking one of those two are occluded. So let's see. Okay, this is where the blood flow is supposed to be. What is this, my cath lab folks? What's that? Is that a cert? It's breaking off. This might help. So this is after we return perfusion. All this is returned. Now this is returned here. There's collateral circulation in here. There's collateral circulation, extra circulation. And thank God, well, a lot of our patients have it. Thank God, hopefully we have it if we need it right now. Who knows, right? We've got a growth factor that works in there. It says, I'm not really getting enough blood. It's a little bit lower than what it's supposed to be. Your EGRF growth factor comes off these cells, and then your circulation system gets that signal and starts saying, all right, over time, we need to keep growing that way and get that area some more blood. That's collateral circulation. It's a beautiful thing. All right, one more, and then we'll go to break. This is an easy one, right? Easy one. So I look at my high lateral. Here's my J point. Is that concerning for something? Sure, that's depression, right? That's depression. J point's down about 1 millimeter. A little easier to see here, right? Agree? J point right here. 1, 2, 3. I know you want to say, hey, well, Dave, it's wide. I'm going to say, no, 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 no. This is your normal complex here. This is your normal complex right here. This QRS stops right here, and the machine knows it. So your QRS measurement on this is not going to be 0.12. It's not. That's why I say look at the 12 lead. Let it do the figure in for you. Okay. Let's count the little boxes. And then the inferior leads, where we're supposed to start over here. Well, here's my J point. Go across. Yeah, it's asymmetrical. Okay, but there's a lot more going on. So we're not going to rely on that asymmetrical thing right here in this one. And in the inferior leads, we don't really look at the symmetry of the T wave. Notice I've been concentrating on it over here. LVH, left bundle branch block, that's where we really deploy our, is it asymmetrical or symmetrical stuff? Not so much in the inferiors. Is that smiling or frowning more? Concave or convex? That is convex or more rounded than it is concave, smiling. Way more. And what's the elevation? 5 millimeters? There's a lot of elevation there, for sure. AVF, 2 or more contiguous leads. Well, I've got 3, right? 3 in my inferior. And then when I've got ischemia, and these are the high or low laterals. Which laterals are these? 1 and AVL are high or low? High. So up high, where these cameras are looking, it sees lack of oxygen. Down low, I see potentially cell death. Makes sense. If there's a MI, or I'm sorry, an occlusion in either the right or the left, I got to figure out what side it is. So looking at this and realizing there's not much elevation over here in the V leads, which coronary artery do you think it's most likely is causing this? Yes, inferior MI. I would probably say an RCA, right? Because in 85% of us, we're RCA dominant, feeds our posterior portion of our heart. The circ comes around that left, but the majority of our posterior feed comes from the preload side, which is the right coronary artery. So if I was to show you that, I'd say, what in the heck is squeezing that right coronary artery, right? You ask anybody in the cath lab, they say, wow, that's tight. And again, we've probably got a little bit of collateral circulation, but you see with the contrast here too, they still have circulation, but it's not as good as you think. Imagery is not always perfect. We don't always have the right measurement of contrast in there too, right? So look what happens when we open it up. Far more defined, far more defined. Far more defined. All right, final break, 8 minutes, 8 minutes. Hold on, don't go nowhere. The time is now 3:40. Please add 8 minutes to that for me. What do we have? 3:48. Back in your seats, please. 3:48. Definitely get up and stretch. Your brains have got to be sweating from all this work. One by one, without all of you going at once, with kind of paying attention to your distancing, I need you to head to the back. Get your transmitter. Do not push any buttons on that transmitter yet. You will mess everything up. Grab your transmitters one by one. Do not push the buttons. Do not push the buttons. For those of you at home who are watching en masse, go get your transmitters in the audience here as we get to the STEMI, not STEMI practice cases. You'll be able to see how they pick from home. All right, you ladies all got your transmitter. Nobody has pushed a button, correct? I'll know if you did. It will tell me which transmitter, yes. A spotlight will shine down upon you. Everybody good? All right, everybody look at your transmitters. Who has a yellow Post-it little sticky thing stuck in the back of your transmitter? Who has a yellow little Post-it thing on the back? You'll see it plain as day. Hopefully Deb gave it out. You got it? Let me see it. Verify it with your neighbor. Does she really have it? All right. You have just one. It's pretty much a $200 book here. Jones and Bartlett does a lot of sponsorship for a lot of these lectures that I do. Yeah. I will bring it to you so that we can keep distancing. All right, everybody at home, you're going to have a chance to win a book too, right? Because I gotta give some love to the virtual side. I have another book. Don't get excited right now. We're gonna, when I call upon my AV maestro back there, we're gonna send out a cue. Okay, so just be prepared when you start hearing that cue. But anyways, let's get back to learning. All right, so we see this right is opened up. What is this right here? Which portion of the right coronary artery do you think this is? Comes off, looks like it's feeding the back of the heart to me. What would you call it? The posterior, Dave? Yes. Come on, wakey, wakey. That would be the posterior. So let's go back to the EKG beforehand. Didn't have as good a blood flow. Now it's got pretty good blood flow. Not just the right coronary artery going all the way down, but that posterior has better blood flow. Can we see that in this? Absolutely. You see these, V1, V2. That is going right down the front, middle portion of the heart, or the septal wall, and it's picking up low oxygen in the posterior area, right? So if I look at this and I go, it's an inferior. Still can be right, still can be left. It's slower, right? Slower rates usually equal SAAV node lack of blood flow, right? Okay? And if I look at 3, and I say, is this elevation greater than the elevation I see here? Which, here's about my J point right there, right? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. J point, 1, 2, 3, 4, 5, 6. Is that greater than that? Yes. And I've got high lateral lack of oxygen and posterior. All right, so let's look at that again. So here's V1, V2 is picking up the lack of blood flow coming off the posterior portion where that posterior vessel is supposed to be feeding. This is pinched, so there's a little bit of lack of blood flow up here for sure. That's my high lateral. I'm seeing ischemia up here on the high lateral portion of the right side of the heart. Are you with me? I know those two leads look side high. Okay, all right, makes sense. And then surely I got a lack of blood flow coming down here. You almost don't need the film to see it. You need the film to fix it though, right? For sure. All right, so that's a right coronary artery inferior MI all day long. All day long. All right. Uh-oh. Do we lose the EKG? All right, you're not going to get to see the EKG. Here's the blockage. Everybody agree they need to be cath? Yes. Here's where it looks. Or here's the increased blood flow straight down. This is absolutely LAD. LAD right here. What leads do you think would have the elevation? Inferiors? Not so much. Left side of the heart where the LAD is. Think about anatomically V1 through V6. Which leads would you expect to have elevation in? V2, right? Not necessarily V1 because it's down a little further, most likely V2, little off the septal wall. where the LAD usually starts. What else? What do you think about V3? Anterior portion of the heart? Yes, it's rolling all into LAD land. 4, yes. Low laterals? Probably. I'll probably see something in 5 or 6. All right. Don't touch those clickers. All right, STEMI, yes, right? You see it right here. It's a messy EKG, but you can see it. I clear the left side out, not much action going on. Right here, here's my J point, couple millimeters of elevation. Right here, my J point, couple millimeters of elevation. I'm gonna cut this in half. That looks symmetrical to me. That is really not frowning either. It's more straight down. Doesn't have that swoop in there like I'm seeing a benign early repole. J point here, I don't see any voltage issues, right? I don't think it's that bucket. There's nothing going down into here. There's nothing going down into here. I think something's occluded and it's on the left side and we should see some blood flow going here. This is really bad, right? So almost a left main. Here's our circ, LAD, and the entire left side. This is the last one. All right, so I run through the whole thing and I say, nah, it doesn't look normal, but I don't see screaming elevation. That's a Q wave. Remember what Dave's saying, if I see a whole bunch of those, that might be something going on right now. I see another Q wave over here, it's 2. And I know it's hard to see these complexes, but I'll give you one here, that's all you need to see. Another Q wave, that's another Q wave. Well, Dave said a lot of Q waves, but do you have 2 or more contiguous leads? No, you only have this. You really only have this. I don't have a voltage issue here or here. I don't think this is anything that has to do with longer amount of transmission from a diseased heart. I don't have contiguous though, thank God, because I don't have to worry about it, right? But my patient's still having chest pain. So I got to figure out, I'm in the CCU right now. I just got this guy back from the cath lab. 9 hours later, he's having chest pain. And I got to look at this EKG that I just pulled because they're having chest pain and think, did something reocclude? No, this is what a CCU nurse has to deal with consistently when they're pulling 12 leads, because these patients, surprise, surprise, still have a little chest pain from time to time. It's the same exact EKG as this. Because there was so much involvement, it's going to take a while for that elevation to go down. And that's why he has all the Q waves in there, and that's why they're probably going to be hanging around for a while. All right. You got your transmission devices ready. Don't push any buttons. We got to review some of the rules at home. You don't have to worry about this. You can just kind of jot it down. Keep it to yourself. Yes or no? I'm sure everybody at home is going to get these 100% correct for sure. All right. So if you look at your transmitter, you have 1 or A as an option, 2 or B as an option, and 3 or C as an option. Okay. 1 or A together is going to be what kind of answer? Yes. 2 or B? No. 3 or C? I have no idea. And that's okay. Don't guess. If you truly have no idea whether or not you think this patient is having a heart attack and I need to activate the cath lab, or I need to call for somebody, or I need to call 911 if I'm over at the rehab center, or I need to get R2, help me out. What is it in the hospital? Thank you. Thank you. To come to my bedside, and I'm going to post this 12 lead that I've just gathered. That's what you're looking to do. Yes or no on these, okay? Don't push any buttons yet. So when you see that little, hopefully, hold on, green light. All right, it's activated. So take a look at this EKG. Once you start pushing your answers, I will see. How many people do we have in the room, Deb? You got a sign-in sheet? That'll probably help me. 33 in the room? Okay, so when that number down the bottom gets close to 30, 33, I will know that we are done. Don't be intimidated by the timer on the left that goes down to 9. That just keeps us honest. We got plenty of time to get through these. Those of you in the back, if you're answering and you don't see like the numbers changing and are stuck, bring your transmitter up over your head and point it towards that. Because you can't answer twice. It's only register once. 17, 19, 20, 21. When we get to about 25 is when I'll consider moving forward, because we'll have a good idea what the room is thinking. One more. Ah! All right, let's see what the room thought. Okay, 59% of you said yes. 37% of you said no. I love the honesty. 4% said I. Okay. All right, so let's look at it. It's slow. This is definitely an inferior MI, right? It's easy to see a right coronary artery is probably involved, right? What did we just do with that other RCA? We said, well, it's slow, right? It's bradycardic. We said if lead 3 is bigger than 2, which if you look at this one and measure it up, it is. 3's got about 4.5. 2's got a couple millimeters. However, look, you don't see posterior changes in V1 and V2. And you kind of see something going on almost everywhere. All right, so the next rule of pericarditis is you do not have reciprocal changes ever in pericarditis. Do we have a reciprocal change located in this EKG? You bet your bottom dollar we do. It's right here. And this one slightly, okay? You will not see reciprocal changes in pericarditis. You will in MI. And this is a bad day. This is a bad day. This is a very useful slide. That stuff that I'm talking about, how to figure out which coronary artery is likely culprit for the elevation levels and all that. Yeah, it's all here. We're not going to review it. At home, email me or Casey, and then you can see all this stuff. All right, you're on. STEMI, no STEMI. Start high laterals, go through your inferiors. Don't be fooled by PVCs. All right, 26% of you say yes, 74% say no. We're all in on this one. There were some folks that just said, I'm not answering at all, but we did stop it at 25. All right, so let's see. Yeah, it is. This is a tricky one, right? This is a tricky one. However, that is definitely almost 2.5 millimeters of elevation. So is that. We look up at that, which we should have looked here first. That's actually going to become a reciprocal change. Here's your J point, right? Millimeter, 2 millimeters of depression. Makes sense too, because they're high laterals, and I understand all these cameras look at certain areas. So high lateral portion over the inferior is showing me lack of oxygen. I don't need to have these, but they're sure helpful in figuring out whether or not that bucket is it, the occlusion. So that's going to be a STEMI based off that evidence. This voltage over here, yep, they've got a voltage issue. It has nothing to do with this part of the heart. Okay. That's a good one. That's a tough one right there for sure. Two people that fast, huh? They're like, no. Those of you at home, it is now time for you to try and win your book. The first one that messages in the answer to this question, what does LVH stand for, wins the book. Make sure that your name is next to your answer, complete name. Thank you. That might have been a hint to this. Holy cow, 30. Dave fell asleep at the wheel. All right, let's see. All right, so 23% say yes, they strong. 73% say heck no, Dave. And 3 say, I'm gonna sit this one out. All right, we respect you. We respect you. You know what we call that in our business in the ambulances? A partner, right? The partner steps out, says, I don't know, you make the call. So it is not a STEMI, it's LVH. I'm sorry, let me zip back here. It is LVH. And the first two, you probably saw this, right? You saw all this ink starting to crop off of the 12 lead. Well, the machine can't produce where it really is, and it's probably clear down here right now because there's not enough time element on this paper. We see elevation for sure. That is a smiling T wave if I ever did see one, right? Or concave, 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 and there's a lot of elevation. All right, a lot of elevation. So this would give you the greater than 2 millimeters. If you're looking for that protection, you got to think about it on your own. And then look at that. We got that. That's not a reciprocal change. That's that strain pattern that I was talking about. That's highlighted on that LVH slide. And then over here, that's not a reciprocal change. It's not typically how they look. That's strain pattern. Green means go. Don't cheat. I'll be back. $18. Whoa, we got some thinking going on up in here. This is not an easy one. All right, 27 in. Rule is 25. I'll let a couple more of you get in there. All right, can we make it 30? Can we make it 30? 30? Hello? Just push a button. There we go. All right, survey says 29% say yes. 58% say no. 13% stepped out of the room on this one, and that's fine. It's a tough one for sure. Now, it is an anterior MI, and this is a tough one, okay? It's a bundle branch block all day long. It's a right one. However, that sure is troublesome looking. It's convex. It's really rounded. All right, and I know what you're thinking. You're like, Dave, you told me about that discoordinate thing. Well, you're right, it is. This is not the typical discoordinates that we'd like to see. This is positive, negative, wide. This isn't wide. It's QRS, it's not wide. And we've got Q waves that have popped up. 1, 2, 3. Hey. So those make me suspect. And then I'll tell you what, when you see AVR matching V1, AVR starting this, again, this camera that is out here really not doing much for us, does a lot for us. We shouldn't see these identical biphasic complexes. So this is tough, but this is where your elevation is. 4 and 5. And if you were EMS, I would be completely okay with you holding off on calling this. It's a tough one. It really is. That's why we call this advanced EKGs, right? I'll give you something a little easier. What do you think? Highlighter, do you see something odd in both of them? Yeah, you just shaking your head yes, and shake your head yes. That make you nervous? Yeah. Correct that. Highlights, right? One in ABL. It doesn't look normal, right? Either one of them is normal. We know what a normal complex is supposed to look like. I'm not asking you to pick it out, tell me what it is. It just doesn't look normal. So that's 1, 2. The inferior leads. Every single one of them got something going on in it, doesn't it? Okay. All right. I'm traveling on to V1, V2. V1, not so much. Well, if I go over to the right, the far right, that complex right there, it's not a PVC, but it sure doesn't look normal. V2, now I'm seeing like a S, double S. Let's see an elevation. V3, slight elevation. Almost looks like a fish hook in V3. V4, slight elevation. V5, slight elevation. V6. And now look all the way up at AVR, the lead that does nothing for you, that does everything for you in a lot of these EKGs. 27, I noticed the count slowed down as I was talking, so people were probably slowing down and saying, wait a minute, he's not going to be babbling much unless he doesn't think it's a STEMI. So let's see how we did. All right, 48, and I expected this because there is elevation for sure, right? 48% say yes, 2 say or 44%, we pretty much got a split room for the most part as far as this polling goes. All right, so let's look at this pericarditis. Do any leads have a reciprocal change? Yeah, one does. The one that sits way out here that has nothing to do with reciprocal changes, but looks down at the heart and says, I see a global issue of a little bit of lack of oxygen. Well, it makes sense because the pericardial sac is inflamed and the whole outside layer of the heart is probably being deprived of oxygen right now. Okay? Slight elevation in every single lead. Patient's chest pain improves when they do what? Lean forward, right? Lean forward. All right. Good job. I like to see that you got it. You got the elevation. We do that same one again. I promise you it's going to be almost 100% say no. All right, let me activate you. Hold on. Those of you hit your buttons. We got to be green. All right, you ready? You ready like Freddy? Yeah. There's a couple of curveballs in this one. Take a second to look at them. Walk a lap around the room, and when I return, you better answer. Yes. Good circulation. Trying to get my collateral circulation enhanced in case I have it. Come on. Should be 25 by the time I get up here. Oh, look at that. All right. Survey says another tide, and I kind of expected to see that on this one because those PVCs are a pain in the butt. All right, so what we got here is a failure to communicate because this PVC is really screwing stuff up. And I would expect somebody that's having an MI to have a lack of oxygen and be throwing off some premature ventricular contractions because at least what the book says is that area is irritated because of a lack of oxygen. So it makes sense. And then what makes this grouping right here concerning? What was Dave talking about? You remember when I had that one slide up there with repolarization and depolarization, how good the one part where you don't want a cardiovert? Right on top of that T wave. Is this PVC firing pretty close to that T wave? Yes, we are close to what, this is a live patient, by the way. This is real. We are close to what is called the RNT phenomenon, right? This patient is potentially going to wind up in VTAC, hopefully not fib, right? Real soon by its own heart's electricity. Crazy, huh? So I would expect PVCs. This is where we should be looking. There's a Q wave. That complex is small, right? So you're going to be like, Dave, I don't have a millimeter. You do. It's a small complex. Look back at your patient and go, are they big? Is the skin surface larger? Energy has a harder time getting out of the heart to that machine then if it's wider out here, okay? I'm not saying full of adipose tissue. I'm just saying if they're wider surface. That's exactly what this patient has. That's why the complexes are smaller. How about that? That's a millimeter. How about that? Would you call that a reciprocal change? Yep. Yep. But those PVCs usually cause people to pause and go, I don't know. And then they go, well, the complexes, yeah, that's not really easy 1 millimeter. It is because the surface of the skin is larger. And then you've got that reciprocal change as great support. All right. I'm sorry, I know at home they can see that. I know the front 2 rows can see it. If you're having a problem seeing it, I'll just tell you the answer. How's that sound? No, you've got booklets in your hands. Everybody at home's got it in front of their face right now. So if you're having a problem seeing it, take a peek in your booklet. I'll give you a hint. Yes, it's a bundle branch block. Congratulations, Jordan Hayes. You were the winner of the book. Is there concordance or discordance that's obvious in this bundle branch block? Do I have this? Do I have this? This is bad. T and an R heading in the same direction. I kind of want to see them doing this. Okay, we're past 25. So everybody says, ooh, 50-50. 50-50. The arm wrestling here, right? Urgh. Well, what do you think? Let's see. All right, so there is an anterior MI going on. And if I was to say, is this concordant? That R and that T, first off, it just doesn't look right. Definitely doesn't look right. The R and the T are heading in the same direction. And the same thing is happening here on 4. But I can make it even easier. The old-fashioned rules of a garden variety ST segment elevation still apply. So the J point is there. The J point is there. V3, V4 are contiguous to each other. I've got 3 millimeters in each leg, right? Plus, I remember the thing about bundle branch blocks and concordance being bad. And then this looks right there. Again, it's narrow, right? So that whole discordant thing is when they're wide, like this. That's narrow. So this is J points up. It's 4 millimeters. So I have 1, 2, 3 contiguous leads technically. V3 is contiguous to 4. 4 is contiguous to 5. Is 5 contiguous to 3? No. It has to be 3, 4, 4, 5, 5, 6, 6 to 5 is fine. 5 to 4 is fine. You cannot jog. That's why this area of the 12 lead has numerics. Capiche? All right. Activate. This is a tough one, for sure. Remember what I said about small complexes, though. Starry, starry night. Trying to think of all the elevator music I know. On hold music. All right, we've hit 25. I'm gonna let this go a couple more. All right. Wow, that was fast. That's a couple more. Okay, let's see. All right, 34% say yes, 62 say no, 3% stepped out of the room. All right, so it is, but yes, this is a borderline one. Now, when you got these borderline ones, again, beware the small complex. Is my patient's skin surface a little larger than usual? Okay, I got it. I agree with you 100%. There's a 0.5 millimeter there. Almost 1.5 millimeters there. But you can justify yourself if this patient is large because you have what above it? A reciprocal change. Right there. And you got another one here. If I don't have these, I take a step out of this room. I still probably get somebody's attention, say, hey, they're really symptomatic. But if I don't have reciprocal changes, I'm not going to say, you know what, this is definitely a STEMI. Now, follow the rules is absolutely what every committee will tell you, and I back up these committees. Follow the rules because it's more likely that you won't get in trouble. We don't ever get in trouble. You won't make the wrong call for the patient. So you would be completely fine to say, you know what, I got somebody to look at it. I rung the bell, but I didn't say I really think it's a STEMI. It's okay. This is tough. But we wander around, we got more evidence here. We got another reciprocal change right here in the posterior portion of the heart, right? Remember, V1, V2, usually see the front to the middle. It's picking up low oxygen in the back of the heart, okay? So all that collective evidence, I'm gonna jump a little bit more over the 50% line and say, yeah, there's a STEMI here. However, I'm gonna protect myself and not activate it because I don't quite have the millimeters. I got all this other evidence. All right, good job. Green light. And they're off. I'll give you a hint on this one too. It's a bundle branch block. What kind of bundle branch block? Left. Right? QRS 0.12 or greater, it's 0.14. We'll say right at the cusp, 0.13. Then I look to V1, the negative. Turn signal down or to the left of the car. And then the bonus stuff, is it new or old? Well, it looks a little oldish because 1 and V6 are positive. Positive. Remember I said that before? Right bundle branch block, 1 and V6 will usually have slurred S waves. Slurred S waves. Well, that's really advanced. Who cares about that? Anyways, back to this. Is there an MI in here? Of my 3 buckets, and yes, there's elevation there. We see it. Of my 3 buckets, is it coming from a metabolic issue, a voltage issue, or a plug in the plumbing? And voltage does encompass bundle branch blocks. 21, 22. We're gonna let this one go right to 30 because it's important. Two more. 29 and 30. All right, 27% say no, 70% say yes, and 3% say I have no idea. All right. Opposite? Yeah. So did I say it wrong? I'm sorry. 27 yes, 70 no. Yeah, you're right. You're right. Wow. Okay, that's good. I'm sorry. Either way, I don't get my heart broken. But when I would have realized that, I would have been like, what in the heck? Not everybody should have said a left bundle branch block is a STEMI, right? So we've got elevation, but that elevation is coming because the left bundle branch is not doing the primary communication. The left is closed off. Who's doing it? The right, right? Instead of that energy coming straight down the left now, it's coming off the right to the side. That's why we have the QRS starting to widen out because one half of the heart is making up for the other half of the heart that's completely out. But instead of going down, it's coming sideways. Capiche? There should be some light bulbs exploding in your head. Wow, that's exactly why it's a little wider on a bundle branch block. Yeah, instead of going straight down, it's got to go to the side. You see that all in the EKG. So yes, there is ST segment elevation. However, it's coming from the left bundle branch. I do not see any abnormal concordance in here really to back it up either. This is just a garden variety left bundle branch block. Good job. You're green. This is a really tough one. That's why only 2 people have answered so far. Look at the whole EKG. There's quite the story here. I want to sit down while you figure it out. Do what? That's not heart healthy. Sitting down? It's foot healthy, I'll tell you that much. You hang out standing in these boots for 2.5 hours. Everybody on in the field right now are going, whatever, Dave, jump on the truck and stand in your boots for 12 hours. They're new boots. I'm trying to break them in, and they're really starting to hurt. I got to get past that phase, right? A couple of blisters, and then they're going to be the greatest thing ever. All right, 25. We'll let this one go to 32. Not 32, 30 as well. 27. 28. I need you, 29. Where are you? We can do it. We've done it on other slides. One more. You have transmitters in front of you, Deb. You can whip one out right now and go bang. All right. 66% say yes. 31% say no. 3% out of the room. Okay, so this is a tough one. Now, it doesn't quite meet criteria, but you absolutely need to get somebody's attention over this, okay? So what we see here, high laterals. Okay, we see high laterals. We see just a Q wave. If we see one Q wave, who cares, right? Okay, so now we're starting to see, here's your J point. I see ischemia. I see ischemia. I see ischemia, okay? We don't call them reciprocal changes until we start bringing them into, is this ST segment elevation I'm seeing somewhere else, right? Coming from an MI. Then I call, right now it's just low oxygen, okay? So, boy, does that look unhealthy, right? But then, flattens out, right? So right next to the beginning of the left ventricle, right, the septal wall, it's like I've got infarction just right there, and all of a sudden next to it drops down. Okay, J point, you can't see it. I can, barely, a little bit low. Fine, drops down, 0.5 millimeter, drops down, 0.5 millimeter. So I've got 1, 2, 3, 4, 5, and then what in the heck is going on here? Everything we've talked about is pretty much showed ischemia up in that lead, right? Or positive, it's VTAC. It's not VTAC. That looks like it's seeing a global MI. What kind of is? It's looking way down at the top of that heart now, and it's seeing something going on at the top of the heart because it's enough for it to see actual elevation, okay? So whatever this is, it's going on at the top of the heart, okay? And we're seeing signs that globally, at least in some areas of the heart, it's a little low on oxygen. So this is going to be one of 3 things. Left main, complete occlusion. I'm sorry, 4 things. Left main, complete occlusion. Global disease, meaning most of the left main and all of its friends that go with it, you're talking about 75 to 80% stenose throughout, okay? Usually when these folks get excited, meaning constriction, boy, does it look like they're having a heart attack, but we usually are medically managing them. Or saddle embolus, lack of blood flow in the very top of the heart, worst possible PE you can have. Or they just smashed into a telephone pole and ripped that little piece of cartilage off their aorta that's attached to their spinal column, and they have officially bled the heck out, okay? An aortic tear, a higher thoracic aortic tear, okay? All of those sound pretty emergent to you? Yes. So when you start seeing EKGs like this, get attention right away. Green, go. When I teach, I like to reinforce things sometimes right on top of things. So if you think you're seeing something similar, you are. Remember, get attention doesn't mean activate the cath lab, because you're supposed to go by our criteria. Sometimes you just activate. This is the last one because we're at closing time. Don't get up and run out of the room though after this. Okay, you're gonna go home with your transmitters. We don't want that to happen. I'm gonna come and arrest you. Not really, you'll probably shoot me off your property, but we can't lose those transmitters. Just don't go anywhere. As soon as we hit 30, we're gonna take a look at this one. 30, 30, you can do it. Oh, come on. Deb's grabbed the remote, I see her. Hey, 43% say yes. 57 say no. All right, we're all in on this. Nobody said I don't have any idea. It is. So this is almost the same exact thing, only a different patient. Looks a little bit different. We got widespread ischemia. It's easier to see now in these, right? Because it's down a full 1.5 millimeters. You see it, 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 you see it. You see it here? It's almost 9 leads. That looks really sick. And again, we've got a matching camera view on the outside that says the whole thing has an issue, meaning the top part. The top part, okay? All right, let me zip past these. Those of you at home, email, you'll get the whole thing. All right, this slide has how to get a hold of me. Yep, there it is, my email. That is me, Halloween, when I was 10 years old. No, it is not. Doesn't it look like it could be me? He's a little more Latino than I am, though, because he is. EMS12lead.com. Tom Boot Laydown, South Carolina. That's a great website. The books that I've given away, 12-lead ECG, The Art of Interpretation by Garcia and Holtz is my favorite. However, that is not the newest version. The newest version just has Garcia. It's written by a paramedic and an MD, aka cardiologist, together. So you get a nice allied health cath lab blend in those versions. And then I like Dr. Smith's ECG blog. Any questions, you can ask me. Whenever, shoot me an email. These guys in the back know how to get a hold of me. Those of you out there in virtual land, same thing. Just get a hold of us via email. Thank you, everybody at home, and thank you, everybody in the room for your time. I hope you learned something. Transmitters, one by one on the table back there, and then you can shoot out and have yourself a great evening. Casey's got to wipe them down before we put them in the box, so please don't. Everybody come running up. Try and social distance a little bit.